I've been looking for a while. It was an adventure. I've been probably looking for 2 or 3 years. Like I don't know what your experience with commercial real estate is, but it's a different ballgame than residential. There's no like MLS. It's all these different commercial brokers with like pocket listings. So you kind of have to like, yeah. Yeah. So like, I just was like, there was one guy that like I see everywhere, and he was like, yeah, I'll come across like listings and like, or they say they want to rent it, but then there's a possibility that they'll buy it if they get a good enough offer. So like, what?
That's why you don't invest in real estate anymore.
Yeah.
I guess I hear that you're supposed to be investing in coins.
Coins, Bitcoins?
Yeah.
So finally, like, I was getting like one guy kept feeding me stuff, and like nothing would fall through, and then finally, like some specific medical real estate agent, they somehow got my email, and for the last year or two have been emailing me with just different ones in like Costa Mesa or like, I don't know, different parts that I just wasn't interested in. Mm-hmm. So I just called them and I was like, if you ever find anything in Huntington Beach, let me know. And they're like, no. And then like 2 weeks later, they're like, well, there's one that's on the market for lease, but we have a good relationship with the seller, so if you offer them a decent enough price, they would consider it. And so all of it, I feel like all of it's off market. Like you're gonna have to find something off market if you're gonna want something.
So today we're doing some portrait sessions about our TADA lecture.
Yeah.
And so we're having our meeting today after the lecture.
Okay.
We could just have this
All right, cool.
Awesome. Thank you.
Tissues at all?
Yeah. I'll go get you some. Yeah, I was reading an article about how every single company right now is having a shortage of people that can't hire people.
Yeah.
And we did an internal survey as to how many people were investing in coins and stuff. We had 80% of people.
Invested in Bitcoin?
And
Or some type of crypto?
Some type of crypto. And more than 50% said that than your annual salary.
Oh.
Yeah. So that might be one of the reasons why everybody's not working.
Are we almost ready to go?
Yeah.
So
We're going to show down people, but I think we could start in about 2 minutes.
Okay. Actually, hold on. Cool. All right, let's get started. We have a full day ahead of us. Housekeeping first. I'm actually going to switch the schedule up a little bit since there's people online. I don't want to like do a lecture and then take a break and then like have these people just sitting there for like an hour and a half as we do hands-on stuff and then go back to lecture and then go back to hands-on. So I'm gonna do all of the lecture right off the bat. It's gonna be about 3 hours. We'll take a little bit of a break at like the 1.5 to 2 hour mark for about 5 or 10 minutes. Then we'll come back, I'll finish it up, and then we'll have lunch, and then we'll go ahead and do kind of the hands-on portion in the afternoon. So if we want to do a really short lunch and then get back here so then we can all get out and enjoy our weekend, we can do that. So why are we here? We're going to do everything that I'm going to be talking about is guided. I think I can count on one hand how many implants I've placed non-guided in my life. So I almost do everything guided. Sometimes I make my own guides. Sometimes I have True Abutment and Urus make them for me. But with all of these guides, we can actually start getting away and doing some pretty advanced implant dentistry fairly quickly. So we're going to be talking about multiple implants, not just onesies, but twosies, threesies. We're going to talk about why guided and getting them perfectly parallel are going to be really important. We're going to talk about immediate stuff, immediate extractions, immediate placement, immediate load, and then actually immediate provisionalization and how that can all be done and pre-planned. So every single piece along the way can already be made for you. So it can be very, very simple at the time of surgery to go all the way from putting an abutment on and temporizing it all done beforehand. And then we're going to talk about doing some internal sinus lifts and kind of what to look for and how to do that and how to maximize the guide to make it really, really efficient and really simple. So that's kind of the game plan for today. Restrooms are going to be directly behind that door right there. Don't be surprised if you open up and you see two guys looking at you. That's where all the technical IT stuff is today. But you're going to hear me talk a lot about why. For me in dental school, I was always the annoying one at school raising my hand, but why do we do it this way? I think when we ask why, it's really important, and it kind of creates us to really understand what we're doing and why we're doing it. And I always like to start all of my lectures with this simple video. So let me get out of the way. So pretty simple, just watch the white team and how many passes do they make. Focus on them. And the answer was 13. But I'm going to rewind the video real quick. Did you guys all see the bear that walked through the middle of the screen? So don't focus on the team in white now as you see the bear walk through the middle of the screen. So I was recently at a conference and they were talking about if you can't see something, you can't diagnose something. I think that as a dentist, we see teeth, we see tongues, we see things every single day. But if you don't know what to look for, if we're not educated on what to look for, we completely miss it. So I'm hoping today to give you guys at least 1 or 2 nuggets to take home with you so you guys can see things differently, treat your patients differently, and kind of set up all of your treatment for success so it lasts a really, really long time. So to kind of go back to why we're here today, it's to avoid stuff like this. So that should have been a pretty straightforward single implant. This is a patient that now we're not dealing with just a 1-tooth issue, we're actually dealing with a 3-tooth issue. They've put the implant in, hit the apex of tooth number 6. This tooth number 4 is now completely mobile. So we've had to take out the implant, we've had to take out tooth number 4, we've had to do a root canal on tooth number 6, and now we're left with these giant defects because it wasn't placed in the proper way. If they took a little bit of time and planned it and used all of the pieces of technology that we have, intraoral scanners, cone beam, it could have been a very straightforward and kind of simple implant. But now it's a giant mess. So You're going to hear me, like I said already, you're going to hear me keep saying why are we here today? And it's to kind of help you guys take your implant game to the next level. We're going to talk about why a crown down approach to implant planning is so critical. If we don't have a game plan and we don't know where we're going, we really don't have a roadmap to get there. So we need to start where the tooth is first, figure out if there's enough bone there to put the implant, and if there's not, do we need to do grafting first? So we really need to start with the ultimate end game in mind. We're going to talk about fully guided, fully timed, keyless implant placement. That's a lot of words, and there's a lot of stuff in here real quick. So fully guided, to me, that's a guide goes on, all the osteotomy drills go through the guide, and that means final placement is through the guide as well. There's some of these systems out here where you do an osteotomies through the guide, you have to take the guide off, and then you put the implant free-handed at the end. What we're talking about today is all the osteotomies through the guide, implant through the guide to make sure you're going in the right direction. Fully timed. This is where it's critical, especially when we're talking about where we need to have prefabricated components at the end. So if we're doing an immediate temporization, the timing is going to be critical, so we have an abutment that lines up, and then we have a crown that goes up over the top. And I'm going to show you when we get there on this guided system that are all in these green bags that you have in front of you, how we do the timing to make sure the implant's lined up correctly. Keyless. There's a lot of systems out there where you're going to have the guide, and then you have to put in with another hand, you have to fit a key inside the guide, and now you have a guide, you have a key, then you have to put your osteotomy in, and then you're switching out these keys. This system right here, all of the keys are built into the osteotomy drill. So there's no multiple things, and then you're making sure that the guide is stable and you're not going off different directions. So they've really thought of everything with this Urus pylon kit that we're going to be going over today. And then fully guided, so the exact same things again, fully guided, fully timed, keyless, and now we're going to be talking about internal sinus bumps as well. All of the osteotomies, I'd say 95% of the stuff that we need, or all the stuff we need when we're actually drilling into bone, is all going to be done through the guide. There's going to be some times where we have to take it off and kind of push bone up in there, use some essentially bone packers to get the membrane out of the way and get the bone up into the sinus. That's all in your kit. So we can do internal sinus bumps as well with the fully guided, fully timed, and keyless kit. And that's going to be what we talk about towards the end of today. So we have a pretty small, intimate group. To me, when the learning process happens, it's when you guys interrupt me and start asking me questions, because either I'm not doing my job in clarifying it, but when we go down those tangents, that's where I think the learning happens. So please interrupt me at any moment in time so we can have that interaction and that banter, and we can kind of have fun and learn. I'm going to take a couple minutes and just have everyone go around the room and kind of introduce themselves, where they practice, what type of technology, how are we currently doing implants, so we can kind of get a better feel on kind of everyone's levels and what we need to kind of accomplish today. So.
My name is Robert Weber. I practice in Encino. I have a small office that's packed with Galileos and Omnicam, and everything I've done has been fully flapped and freehand so far. I have actually waiting in a box at my office my first Azento case to be placed. I've never placed one, but I did the records, I put it in, I got it completely.
Cool.
Taking the course.
I'm going to show you a case what Azento is. Azento is everything pre-planned. It's what Urus and True Abutment can do for you for about like a third of the cost. So just something to kind of think about.
Yeah, I did an Azento because the patient has a number 7 resorption.
Yeah.
And I just trusted the process. With
Yeah.
I didn't plan to use it permanently.
Yeah.
But for this particular case, I thought it was a good.
Especially in the anterior, I think that's where Azento
Yeah.
flourishes. They have the exact same thing here. I'll show you a case that I actually am in the middle of right now,
Yeah.
as well. So assuming CEREC, a CEREC office.
Yeah.
Yeah, Omnicam and.
I have both an Omnicam and a boot camp. I actually use my boot camp probably more than my Omnicam.
I'm gonna push you to get a prime scan then, and then then the other two will collect dust.
I've known small practice in Laguna Hills. Been putting implants about going on 23 years, the old traditional way, flat or minimal flat, or single ones, maybe multiple. Would like to do more guided, more full arch cases.
Okay.
And had it set for 20 some years, but the old school, like things like blue cam or red cam. Looking for a new scanner, and just so much has changed. I just feel that I need to learn from young guys like you.
All right. Cool.
I just arrived here, because my English language is not very good.
No worries.
Okay, usually it's a very good idea. It's very important to save time and save trauma in the patient.
Yeah.
Yeah, it's a very good idea. Go ahead.
Cool. Anything else? All right. Perfect.
Jerry Okoloto. I practice in Pasadena. I've been practicing for 24 years. We've had the CEREC system for about 20 years. We currently have Omnicam. I place implants, mostly freehand, simple ones, single units. I placed one guided surgery one, usually flashless.
Okay. Cool.
Been long my practice in San Juan Capistrano. I also have the Galileos in there. I've been doing fully guided with Blue Sky Bio.
Okay.
Also keyless. It's not timed.
Okay.
So that's why I'm interested.
Yeah, then we'll show you the timing. It'll become more clear when you guys physically get to work on the hands-on model. I'll tell you what to look for, but until you actually do it. So I'm going to say a bunch of these things, and then when we open these kits, you're going to look at me again like, what did you just say? We'll go through it all.
I'm not a doctor, but I work with doctors,
Okay.
with many doctors with implant.
Okay.
So we have a practice in Anaheim.
Okay.
My husband dentist, so he's with me.
Okay. Cool. So a little bit about myself is that's me in the practice that I currently work at. Both my parents were dentists, so I truly grew up in that practice. We actually, I have my son who just turned 4, and that's with me at 4. So we put him in the exact same spot. The office looks a little bit differently than it did 30-something years ago. Went to dental school. And during dental school, I had one of those moments, those life-changing moments, I think that a lot of us did. But it really, truly impacted how I was going to practice dentistry. I was on emergency clinic that day, and I had my good old-fashioned pager and got paged to the window. And they give you a chart, and they're like, and you don't know what you're getting in emergency clinic. So I grab the chart, and I literally turn around, and that's where all 100 patients are waiting. I call out the name. And this guy, you know those cartoons where like you see like full arm cast, and like full leg cast, and they're just like sitting there? That's how this guy was. And I'm like, okay. And he's in a wheelchair all by himself. I don't really know how he got there. And I wheel him back, and he doesn't have any help. Luckily, I'm a big enough guy, and I get him into the chair, and we get him in the chair, and I go, what can I help you with? Like, why are you here today? He's like, I broke my temporary. I'm like, well, what happened to you? He was a janitor for the medical school, which was a couple blocks away, and was on a ladder. And like they came flying around the corner with like a gurney and knocked the ladder out. He came falling down and literally broke like half the bones in his body. And he's like, and it's been a couple weeks. I've been in the hospital. I finally got into a rehabilitation center, a physical therapy place, and I can get here to fix my temporary. And I'm like, I got this. I'm a third-year dental student. I can fix a temporary, no problem. I lean him back, And it's not a 1-tooth temporary, it's not a 2-tooth temporary, it's not a quadrant full of temporaries, it's a full mouth rehab. And they're like decimated. Like every like pieces of stuff just here and there. And I'm thinking to myself, like, if that walked into my office today, I'd still be crapping my pants. Like, how am I going to put this together? Because I have no records to go off of. It took me like 3.5, 4 hours of like salt and peppering and all those old school techniques to kind of get him back to function. We get it cemented. And he's sitting there for a really, really long time. And we get to the end and he looks at me, he's like, I really have to go to the bathroom and you're going to have to help me. So I pick him up out of the chair, get him back in the wheelchair, and he goes, please hurry up, and I need you to bring cups. What do we have access to in a dental clinic? We have like the 2-ounce like Dixie cups if we're lucky. So as we're racing to the bathroom, I grab these cups and I carry them with me, and we get to the bathroom, and I'm thinking to myself, I went to dental school, I didn't go to med school, like I don't know what I'm in store for in the next couple minutes. We help him get his pants down, and he's about to go to the bathroom in his wheelchair, and he kind of leans over and he's like, give me the cups. We give him cup number 1, and he fills that up in like 2 seconds. And all of a sudden, I kind of look around and he hands it to me, and now I'm holding a cup of warm urine. I don't ever want to be holding my own cup of warm urine, and I just like chuck it and throw it to the other side of the bathroom. And I give him cup number 2, cup number 3, and then I realize we're out of cups. So now I'm going back to what I just threw out of the trash can, emptying it, and we have this like chain of me going back and forth as we're doing this. And we get to the very, very end, and he spills it all over me. It was that moment that whenever I could get in my dental practice and avoid making temporaries, I would. So, so that's when I finally had some control over my practice. We brought on the Omnicams, we brought on the orthofosses, the CTs. We now have 2 prime scans, and my Omnicam is sitting in the corner collecting dust for whatever trade-in I need it in the next couple of years whenever I need it. But then we had some issues with my parents. My parents had this, what I call the drill and fill mentality. They liked their comfort zone. They only liked to do 1 or 2 crowns at a time. They liked to do fillings. They didn't really want to expand the surfaces that they provided. And I kind of got a little bit frustrated with that. And we kind of had this come to Jesus moment where it was like, I need to take over and do what I wanted to do, or I need to go do and start my own thing. And we finally had that breakthrough. And when we were able to kind of put my stamp on things and really implement and use the technology to its full capabilities, is when my practice really, really took off. So I put this slide up real quick. And I think every time I put it up in lectures to dentists, I think I'm hoping I'm not jinxing myself right now, but what's the easiest thing on this slide to fix as a dentist? Like if you look at that, what are the things that we usually drawn to first? How do we fix that to increase our profit?
Increase revenue, lower overhead.
Okay, right. Okay. So almost everyone, when I give this, is they look at overhead and they're like, we look at supply costs. That's the first thing that we try to do. It's usually the answer I get. I don't know if any of you have looked at the cost of gloves and masks before COVID started, and then at the peak of COVID, what they were going for. They were probably a couple dollars, maybe $4 or $5 a box for a box of gloves. At the peak of COVID, they were like $15, $16, $17, $18 for a box of gloves. What? Yeah. I don't know if all of you have looked at the cost of inflation and how the cost is rising. I don't know about it's really, really hard to find good employees now. I'm paying all my employees more to make sure they stay with me because I'm afraid they're going to leave. So we have this overhead issue where that's not really decreasing in any way, shape, or form. That's significantly increasing. And then for revenue, I think a very typical dental practice is going to be some type of mixture of they're going to take insurance at some point and be in network, so some type of PPO fee schedule. Those insurance companies are either capping those reimbursement rates or in some cases even decreasing them. So that model that my parents had of being a drill and fill dentist where revenue is decreasing and overhead is increasing is not a good business model to be in. You're right, we need to start increasing our revenue. And how do we do that? Do we increase our how much we charge? Yes, that's one way. The other way that I started looking at is to start adding revenue streams, adding the services that we can provide our patients. So looking at doing aesthetic work, doing clear aligner therapy, adding sleep. I do a lot of sleep apnea appliances and work with a lot of physicians in our area. But for me, the biggest bang for my buck that I ever did was starting to add implants to my practice. Implants a lot of times aren't covered. They're still kind of in that territory where we can charge what we want to charge and get our fee-for-service fee, and we're not taking big catastrophic hits from insurance. But implants aren't just a one ticket item. It's like a 5 or 6 ticket item. It's an extraction, it's a bone graft, it's a sinus lift, it's the implant placement, and then all the restorative components to that. So when I started adding implants, that's where my practice essentially took this, what I call the hockey stick curve that I'm going to show. So 3 guiding principles that I use kind of in my everyday life, but also for my practice are the following. And it kind of just, that first video goes over this first principle, is we all saw the same thing, but we didn't know what we were truly looking for. I kind of tricked you and told you to focus on the white team first, but the eyes don't see what the mind doesn't know. If we don't know what we're looking at, and we're not educated on that, we can't implement those skills. So we can all see teeth, we can all see spots for implants, but if we don't know how to do it and we're not educated on it, we don't know kind of what to do and how to move forward and implement that in our practice. So to me, this is just educate yourself, educate yourself, educate yourself. The best investment you can make is an investment in yourself, and be comfortable being uncomfortable. So to me, this is a perfect example of the eyes don't see what the mind doesn't know of. I use this picture as an example of why I use CTs in my office. I think we're all pretty convinced that the mama lion hasn't bit off the cub's head. If we take a different angle, it's perfectly fine. But a PA doesn't show us a lot. If we have that technology and we're able to invest in it and use it and utilize it, we can see a tremendous amount more. So I'm hoping, like I said today, you guys take a nugget from 1 or 2 things today and that I'm teaching and are able to implement that back into your practice, hopefully immediately. Investing in yourself. I know it's pretty controversial when I start bringing up the cost of dental school right now, but I'm just going to use some pretty round numbers. And I know they're going to be bigger numbers for some of you, but let's say on average, a year of dental school is $100,000. So kids are coming out of school with debt of about $400,000. If you're coming out as a first year and you're working 5 full-time, I'm pretty convinced that you guys, a dentist working full-time as a new associate can make probably around $100,000. Let's just do that as a return on your investment real quick. $400,000 in, first year out, $100,000. That's a 25% return on your investment. I know Jay and I were joking about Bitcoin right now, but I think anyone would be happy if we put our money into something and gave us a 20% year-on-year investment. I challenge each and every one of you to start learning some additional skills, because that's something that you can repeat over and over and over again, and it's an investment into yourself and an investment into your practice. So being able to do multiple implants that you can do multiple times, and essentially your return on your investment becomes infinite. If you really are working for another, I mean, for me, I'm probably looking for 20 or 30 or 40 or more years. But even if you're looking at 10 or 15 more years in practice, I highly encourage you to kind of invest in yourself. And it's also an investment in your team. I've attracted more people who want to kind of be in that mindset. I tell every single potential employee, I'm going to push you, and you're going to have to be comfortable with that if you want to stay around. And that's the kind of the people that I want to be around. And it's also gotten rid of people in my office that didn't have that mindset. They didn't feel comfortable in my office because I was constantly pushing them. And you kind of create this team and this momentum to kind of help further your practice along. So keep investing in yourself, kind of always have that mentality to kind of push yourself in your practice forward. And then the getting uncomfortable part. I feel like every time I do a new procedure, everyone is nervous, including myself, the patient, the assistant. They have no idea what to do and how to set it up. And we're all trying to keep this like calm, cool attitude so we're not freaking the patient out. For me, every time I do a new procedure in my office, I do it at no charge to the patient. I kind of pick a patient who wouldn't normally been able to afford it. So my first 4 or 5 implants from start to finish, I did it at absolutely no cost to the patient. What I tell the patient is, hey, you're getting this for free. I'm gonna have some extra people in the room, assistant and a couple of extra assistants so that all the assistants know how to set something up. I'm gonna have the rep in the room, so I'm making sure when I'm especially doing osteotomies and using a kit for the first time, they're pointing to me to make sure I'm using the right drill at the right time. It allows some more free communication and creates a learning experience for me. So I highly encourage, whether it be implants or your first sleep appliance or your first ortho case. My first ortho case was on my brother-in-law when we were closing a diastema. Do all those things so it takes the pressure off and allows you to kind of push yourself to continue to get uncomfortable so you can add these new skill sets to your kind of your repertoire. And it can be very, very lucrative. Think of it just as an investment. We're investing your time today, but in certain times where you're going to invest in a class, think of that as an investment, or doing the procedures is just that additional investment into making you successful. So, and then find a mentor. Find someone that you can, if you're unsure of something, that you can text, call. Find those people that will be able to kind of help you climb that ladder. I have an amazing group of mentors that I can call, text at any point in time if I don't feel comfortable doing something, so they can help kind of pull me up and get to that level that I want to be. And then I talk about synergy. That 1 + 1 is greater than 2. When I see something that I need to bring into my office that I feel a little bit scared of, that's a flag to me that it's something I probably need to do. And especially when I start adding, if I see something like CEREC, when I initially did that first step into the CEREC world, I was uncomfortable. I saw it as an investment in myself, but it was also going to educate me. When I see things just in general for my practice and it hits all 3 of those things, it's something that I know I need to do, and I need to get pushed back that uncomfortable period. So you guys are all going to be learning something new and be a little bit uncomfortable today. But I see it as an investment in yourself, and we're also educating you. So what you have in front of me, to me, is the synergy that hits all those 3 of those targets that I talked about. And this is just what it's done to kind of my practice. Those first 5 or 6 years are the years that I worked with my parents and got a little bit frustrated kind of towards the end. I was still learning in the beginning, but years 4, 5, and 6, I was getting frustrated, getting a little apathetic, and that's where we had that come to Jesus moment, and I was able to kind of take control of the practice and start bringing on the CERECs, bring on clear aligner therapy, bringing on sleep, and you can see all of a sudden how that impacts. And then the cherry on top was when we started bringing on implants. So we've had a tremendous amount of growth over the last couple years. And if you are like me, where I'm almost becoming like a specialist in my office, I'm doing a lot of the extractions, a lot of the bone grafting, a lot of the implants. If you're going to be bringing on associate, that frees up a lot of the procedures that I used to be doing, and giving it to her. So that's another revenue source. When all of a sudden my schedule's full with higher end ticket items, some of that stuff now gets put on my associate and kind of frees up more stuff for her to do. So she's happy as well. So you're gonna hear me what I started with why. It's how I found out about a true abutment and why I love working with them.
The why was born out of pain. It was never an academic or commercial exercise. It was born at a time in my life, many years ago, 10 years ago, where I had lost my passion for what I was doing. I owned my own small business. I was living the American dream. Superficially, my life was fantastic. And yet, I didn't want to wake up and do it again. And I was embarrassed by that. You know, who am I to complain about my life? My life seemed perfect, and yet I hated it. And so I kept it to myself. Every ounce of my being, all the energy that I had was invested in pretending that I was happier, more successful, and more in control than I felt. And it was debilitating, quite frankly. Strange things start to happen when you put yourself in that cycle and the stress starts to build. You start to become paranoid. So for example, I was convinced that my employees hated me. I didn't go out much, and it was really a bad time. And it wasn't until a friend of mine came to me concerned that I wasn't acting myself and basically offered me nothing more than moral support. What do you mean about your act and where about you? And it was that simple act that gave me the courage to face my own problem. And it was that simple act that gave me the courage to seek out a solution, to go back to the way I used to feel, to be passionate about something again. There was a confluence of events, and I made this discovery that every single organization on the planet, even our own careers, always function on the same three levels. What we do, how we do it, and where we do it. And it was based on the biology of human decision making. It wasn't some highfalutin management theory. It was based on brain stuff. And I realized I knew what I did. I was good at it. And I knew how I did it. I could tell you what was different or special about the way I did things. But I couldn't tell you why I was doing it. That was the missing piece. You had to have all three. I became obsessed with this thing called the why. I figured out how to find my why, and it restored my passion to levels I had never experienced before. And more importantly, I figured out how to help others find theirs. And I did what anyone would do. When you discover something beautiful, you share it with your friends. And my friends started making crazy life changes themselves. And they started finding happiness and passion that they'd never experienced before. It was me solving my own problem that happened to help others solve it for them too. And people just kept inviting me, and I just kept saying yes. I was making huge decisions that were really easy to make. Like I shut down my office and started over again because I realized the business I had built was so inconsistent with my why. All my friends thought I went out of business and they worried about me. It was the easiest decision I ever made. In other words, when you know your why, the filter is clear. It's not like there are options. The option is obvious. There's only one option. Share, give, inspire. And everything that I've achieved, any success that I've enjoyed, has all been 100% because of the gracious, just amazing generosity of people around me. My friends and my colleagues, people who just believe what I believe. They're the ones who either introduced me to others or took a risk or said, let me try that, or bought a book or watched a TED Talk, or more importantly, sent it to somebody else because they thought they would be inspired. For all of the things that I've done over the past decade, I still feel like I'm at the beginning. I've been saying it for 10 years, and everybody says to me, you know, congratulations on X, Y, or Z. My answer is always the same. Tip of the iceberg. And I think that's what keeps me inspired, which is, for me, it's a journey. I'm on the right path. I'm walking past the right mile markers. In other words, I know I'm making progress to the vision that I have, to build this world in which the vast majority of people wake up every single morning, inspired to go to work, feel safe when they're there, returning home at the end of the day fulfilled by the work that they do. When I started the race, I ran by myself. And that's lonely. And now I got like 1,000 people to the left and 1,000 people to the right, and 1,000 people behind me. And I look around and I'm like, yep, we're going to change the world. We're going to change the world. There you go.
So I don't know if you guys know who that is. It's Simon Sinek. I think he's a motivational speaker and author, but he has like the highest viewed TED Talk, like one of the top 5 ever. And it's kind of the why. So I think as dentists, we all do the same what. We fix teeth. How we do it, there's subtle differences on how we do it. We could be placing implants freehand. We could be doing a filling a certain way with a certain material and a certain way with a certain bonding agent. The why, I think, is going to be different for everyone. And once you find that, I think everything else falls into place. My why was I wanted to kind of treat patients how I wanted to be treated, and that was using state-of-the-art technology, and that was, for me, digital dentistry. Allowing the patients to get the best possible care possible, giving the opportunity for them to say yes to treatment, and allowing those to do those services digitally. And that's when true abutment, I kind of found true abutment that way. Is true abutment's why, or their vision, is they do the same thing. They make implants, they make abutments, they make components. But for the digital dentist, they make it significantly easier. They're literally, like, I asked them, I have this problem and the workaround with guides or with restoring implants with CEREC. And it's not CEREC and Dentsply Sirona that gives me the answer and the solution. It's usually true abutment that gives me the answer and the solution. So I work with them a lot because their why is making digital dentistry, especially digital implant dentistry, significantly easier. So this is the first time I ran into true abutment and why we need them, especially if you're a CEREC office. I took level 3 with CDocs, came back gung-ho, and really quickly during that 2-day seminar, they were like, yeah, at that point in time in really tight scenarios with tight teeth and a deep implant, you can't use the CEREC system to restore implants. The tie base is only 1 millimeter high over the implant platform. And in those cases that are super tight and super deep implants, you're going to essentially run into bone. And you're not going to be able to engage this tie base. So you can see this is one of my first or second implants getting back, and all of a sudden I couldn't get it to engage. We take an x-ray, and I just hadn't filed it away, and truly learned what they were teaching is that we can't use the CEREC workflow for this particular case at that point in time. What I had to do is then get the patient back, take a traditional implant level impression, and get something like this made. A little bit smaller, a little bit more customized, so the implant can engage and implant can fit. And for years and years and years, all these CEREC dentists have been begging Dentsply Sirona to come up with additional workflows to get higher tie bases. Levels 1, 2, 3, and 4 millimeters above the gum line. And that's what true abutment essentially created for us. Is we have these variable leveled tie bases that allow us to still restore these implants with the equipment that are in our office. So we do this for one of 2 reasons. One is to avoid the crustal bone so we can get the tie base to engage with the implant without needing to bone profile it. And then 2, as this abutment gets taller, it gives the crown more support. Then they took it one step farther. So these are just the different heights. You can see in this particular case, this GH1 isn't fully engaged because there's some gaps. As soon as you get the GH2, it works. And then if you want to do additional heights, 3 and 4, you're just essentially increasing the height. The other thing that we were complaining about is it happened to us a lot of all of a sudden we put the scan body in, we scan it, and then we realize we can't use that particular tie base. For whatever reason, the patient's already gone. And now we have to either call the patient back and do some more impressions or more scans. What they allow us to do is now a whole host of different options based off of just their scan bodies. So GH1, GH2, GH3, GH4 scan bodies, if you send that to True Abutment, you can use your tie base, or you can have all of these different options that they will completely customize for you. If you want a custom abutment, all of a sudden the screw channel is going to be coming out the facial of an anterior crown. They will then move make a custom abutment and get that, do a cement retained restoration. They can do a full titanium crown. They can even do a angulated screw channel. So that allows us to then, if you're adamant that you don't want a cement retained restoration, they'll angle the screw channel and still allow us to do a cement retained restoration. If we're starting to do full arch stuff and we don't have the right angled abutments for our all-on-X's and prosthesis, you can put on one of these scan bodies and they will customize an all-on-X multi-unit abutment for you. Completely customizable with some pretty absurd angles for you. And then there's a case that I'm actually working on right now, these customized locators. The surgeon that I'm working with placed an Astra 3.0. Astra won't make locators for a 3.0 implant. Well, we had treatment planned for a locator denture. Now I'm kind of stuck, but they have the option to create customizable locators as well for any implant out there by using their scan bodies. So a whole host of different options, and I don't have to guess what scan body I'm using today. I have one scan body for that particular implant, and I can put it on and know that I have 6 different options to choose from to restore that implant. It gives me a lot of freedom to do it. So, if you guys want to learn, it sounds like almost everyone here is CEREC, and if you're not restoring implants with your CEREC machine, to me it was one of the most lucrative investments in the CEREC machine that I ever made. There are courses just like the course you're here today. I think it's in about a month or so in here, going through how you restore single unit CEREC crowns with the True Abutment system. So the next problem that I ran into in my digital implant workflow was this problem when I'm making surgical guides. I don't know if you can see here, but this is essentially the sleeve that is going to be directing my osteotomy here. If you're using CEREC, most of the time you're stuck with where this sleeve is. You can't move it. Well, I can't move these teeth either, so I'm essentially stuck at this point if I want to do something fully guided or a guided surgery, because my sleeve won't fit and these teeth won't move either. So I'm stuck. What they came up with as a solution is, if you in the CEREC world, it's called a D2 value, where this value can be moved up and down to get this sleeve so it doesn't interfere with this guide. So they've come up with a solution, and it's called their Universal Keyless CEREC Guide 2 Kit, which I don't know if it's over there, but if this is something you guys are interested in, I'm sure they can bring it out for you. Where that guide sleeve can be moved in multiple positions, so you guys can still make your guides in-house. Now this is not fully guided, but it's keyless. So all of the osteotomies are done through the guide, and then the last thing that you have to do is to place the implant free-handed at the very end after all your osteotomies are done. So still a really nifty workaround if you want to be making your guides in-house and you run across problems like this. And those are kind of the D2 values, these values that move that guide sleeve up and down. And it kind of just gives you a pathway of a certain way to go depending on your D2 value that you set. So let's talk about, real quick, implant placement fundamentals and why we're all here. So, to me, it's where do we want to place the implant? How do we make sure it stays there? And then how do we make sure it functions? Just make sure that once we make a restoration, it's going to last a really, really long time. So to me, the first thing that you're going to need is some type of 3D technology. The workflow that we're going to be talking today, that's a requirement. You need to have a CT scan to send them. So if you don't, that's going to be the first investment. Allows me to see a lot more, allows me to diagnose a lot more. I see radiolucencies or periapical pathosis left and right, especially on root canals. I'm a big believer, especially now that I'm placing my own implants, is I'm fairly aggressive if I see any failing root canals. To me, it's like incipient decay, even though it might be small. I'm either getting it retreated or giving the option if the patient's done with trying to retreat it and do what I call hierodontics on some of these teeth, is to try to take out that tooth. If it's an incipient decay, we still go after it and put a filling in there. If it's a small lesion, we know that lesion is going to continue to grow, and as an implant dentist now, I'd rather get an infection out when it's small and make sure that bone grafting procedure is very predictable and very straightforward, instead of going in there 2 or 3 years later, seeing this lesion that's huge with blown out walls or huge furcation involvements where that bone grafting isn't going to be as predictable, especially in the maxillary where I'm now having to deal with sinuses as well. So it's an amazing diagnostic tool. I think Gordon Christensen actually just said that was the #1 thing that you should be investing in now for his list of 2022 if you don't have one already. But on the implant side is why cone beam technology is we can avoid vital structures that we need to know that are there. Nerves, we don't want to have any infraalveolar nerve injuries. We want to make sure the patient's not bleeding out and all of a sudden what looks like this great amount of bone in the mandible, all of a sudden there's some huge sublingual fossa, and we have essentially a patient bleeding out where we accidentally hit it because it looks great, but all of a sudden there's a fossa here. We're making sure that we're not going through buccal plates or lingual plates. We know where the sinus is, and we're really making sure there's enough bone in all 3 dimensions, not just the 2D that we're used to. So let's put all of that together, and these are kind of the standards of where we want to place implants right now. We need to place it 3 or 4 millimeters deep from the gingival margin of that implant crown. And this is where we talk about the importance of a crown-down approach. If we don't know where that implant rest margin is going to be, how do we know what is 3 or 4 millimeters deeper than that? We have no idea. So when I have all of these surgeons that say, oh, I don't need a guide, I'm just going to be freehanding it. I've had circumstances where they've placed the implant great, buccal lingually, facially lingually, or mesial distally, facially buccally, but they didn't place it deep enough. And it's really tough for me to restore it then. Because it was a short tooth, tooth number 18, not a lot of clearance, and then it kind of puts me in an awkward situation as the restoring dentist. So design where an ideal crown is, and then 3 to 4 millimeters deeper is where we want to have that implant platform. We want to have 3 or 4 millimeters between implants if we're going to be doing multiple implants. We need to be 2 millimeters from the buccal plate, and we need to be 1.5 millimeters to 2 millimeters from adjacent teeth, and 1 millimeter subcrestal. This is kind of what all the research is stating at this point is ideal placement for these implants. If we don't know where the tooth is going, we don't know, a lot of these measurements we can't figure out, especially the first one. So, and that's a lot of numbers to think about. I mean, we can eyeball it and do our best guess, but if we're going to be threading the needle on some implant placements, especially in the front or the lower anteriors, we need to be right on for all these numbers. And it's not something I can just eyeball. Especially for someone that I didn't go to specialty school. And if I want to be placing implants at the same level as all these surgeons that have gone through residencies and are now doing them hundreds of times a month or a year. I needed to leverage the technology and the guides to get me to that level. So just kind of to reiterate in pictures what we're looking at, about a millimeter, 1.8 to 2 millimeters from the buccal plate. And these are numbers that you need to hit, especially in the anterior and aesthetic zone. About 1.5 millimeters to 2 millimeters from adjacent teeth, 3 to 4 millimeters between implants. And then a depth of about 3 millimeters deep for where you want the gum, essentially the tooth, to emerge from it. This just talks about why we need to put it a little bit deeper. If this article and this guy, if you look up him, he does like all the research in Sweden on like the ideal placement for implants. For a normal tooth, that biological width is 3.1 millimeters. For teeth, for implants, it's a little bit bigger. It's that 3.8 to 4 millimeters for ideal placement for the gums to grow. Sorry, I know you were taking a picture. Good. And if you guys interrupt me at any point in time. The other thing that we want to do from a crown down approach is if I'm trying to do all screw retained restorations, if I'm not designing where the crown is going to be, I don't know where that access hole needs to be to make sure I'm going through the middle of that crown so I can do it with a screw retained restoration. I also need to make sure that proper depth of 3 or 4 millimeters. But if I'm going ahead and planning these implants and I see something where I can't get the implant and the screw access hole coming out and I'm going to have to do a custom abutment, I can treatment plan that for the patient and give them an estimate that we have to do a custom abutment in either cement retained or angulated screw channel, and give that to them ahead of time so there's no surprises or oopsies when all of a sudden I either have to eat the cost for doing that custom abutment or now the patient has to pay a little bit more. We know about that all ahead of time and can pre-plan that and give patients really, really accurate estimates. And then you have cases like this where this is a surgeon that I've worked with hundreds of times, and it's like, I don't need to do guides. I've done hundreds of them and I know how to place implants. That now makes my job extremely difficult. This patient he's really hard to difficult to work on. Huge tongue, huge cheeks, limited opening. So I see why he ran into this issue. I mean, he almost hits tooth number 29. Now, from a restorative standpoint, I can't do screw retain restorations, which is what I had treatment planned the patient for. Now I'm going to have to change it to custom, and the patient really isn't happy when all of a sudden I think I ended up eating the cost and then sent it to True Abutment, put the scan bodies on, and sent it to get restored. But if I can be predictable and have these planned, the surgery is a lot easier. You don't have to put these little pegs and then you're eyeballing it in the back of the mouth to make sure they're parallel. Everything's done and you can go like zoom, 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 zoom and do these osteotomies at the same time. These are now my favorite procedures. I can do 2 implants in the time, and it takes me 2 seconds longer to do the second implant, and I can get it perfectly parallel. And that's where we can start taking guided implant placement kind of and start doing multiple, like more, another revenue stream instead of referring that out. And then you can also see, which I don't know when I'm talking about this, but these are all customizable healing abutments. This is where the timing comes into effect. I'm going to show you why on all my cases I'm doing customized healing abutments now. It's coming up, but that's where the timing comes in. We know there's going to be a notch on the healing abutment that lines up with the notch on the timing of the implant, and all of these are prefabricated and done before, while the surgery is planning and before the surgery is taking place. I am taking ISQs on all of my implants. An ISQ is what's called an implant stability quotient. You put a little metal peg on the implant itself. You take this wand and it gives you an objective measurement on how well that implant is in the bone. So I take it the day of the surgery I get a number. Anything above 50 to 60, 65 means you don't want to be touching that implant, you want to be burying it. Anything greater than 65 means you can actually start loading it, whether it being a healing abutment or actually loading it with some type of temporary. I would just highly recommend taking it out of occlusion. And then you follow it up. So we take it day of surgery, we need to let it to heal for 3 or 4 months. At 3 or 4 months, we look at the number, make sure it's increasing. If it's increasing, we know that implant is very stable, and you're gonna have good long-term success with it. And it's an objective measurement. I feel like torque on how well the implant bites and how well you torque it in is a lot of feel, and it's a lot of subjective, like how well it felt. I mean, you can get an actual objective measurement, but it doesn't often tell me a lot. I've had implants fail that went in with high torque values, that there's no correlation between torque value and long-term prognosis for that implant.
So what is the name of this machine? Where do you get it, and how much does it cost?
So there's 2 different companies that are doing it right now. The one is called Austel. One is called Austel, and the other one is, so it's like a little wand, you put these pegs on, you scan it, and it gives you this number. You're gonna see in some of the, I think in some of the videos that I took of me placing implants, I have it real quick and you'll see me do it. The other one is made by a company called Aseptico, and it's called the Penguin. I personally like the Aseptico one because the pegs are reusable and sterilizable. So you can put them in the sterilizer, have them come back, and you can reuse them multiple times. That one, I think it's like two grand, and I think the pegs themselves are like $10 or $30. Go on like aseptico.com, type in the Penguin, and it gives you each implant you have, each restorative service you have needs a different peg. So like with Urus, they have 2 different restorative platforms. They have the narrow, which is the 3 and the 3.5. You need a specific peg for that. And then the restorative services for 4, 4.5, 5, and 5.5, and I think they might have a 6. All stem restorative platform. That peg I know because I used it what's today? Friday, Wednesday. That's a 10.
So do you screw it into the implant? Okay, so it's proprietary for each system?
Yeah. Yes, more or less, yes. There's some that like, when you have like some of these knockoff implants that are the stem restorative platform, you can use that same peg. And they tell you what implant you're restoring with. That'll tell you which peg you need to order. So just kind of with that, with how implants work is you get your primary mechanical stability, and then on the 4th day in the 4th week, you actually get this decrease in stability around the implant because of the trauma that you created with the osteotomy. And then they need all of this blood supply and bone growth. And then at 6 to 8 weeks, you actually finally get new bone growing around the implant itself. And that's where all of a sudden the ISQ values start to go up if it's integrated. I've gone in there and restored implants, and all of a sudden my ISQ is like significantly lower. I push a little bit harder, and all of a sudden we have a spinner and we have to take it out when it fails. So that's how you know as well. Instead of all of a sudden restoring something, they come in a couple weeks later, it doesn't feel right, or all of a sudden it's loose. You can know that a little bit more ahead of time. And this is where we're just talking about the trend. Measurement 1, measurement 2, measurement 3. I'm usually only taking 2, day of surgery and then day when I'm starting to restore it. So I know a lot of you were talking about punches versus flaps. And I think a lot of people, especially when you start doing guided, are like, ooh, we can just do a tissue punch. I'm still a little bit old school, and I still recommend flapping. One is if we have that we need at least 2 millimeters of keratinized tissue around the implant. And the reason why I flap is a couple reasons. One is if I'm short of keratinized tissue, I can move the flap and design my incision in a specific way to get the keratinized tissue where I need it to be by moving it when I do that. I can also visualize the crest of the bone. So while all of these guides are extremely accurate, the CT scan can sometimes be off with where the bone actually is. And we may be a 0.5 millimeter off, maybe it's not deep enough, but if we don't have that flap, we can't see. The other reason I like it is all of a sudden, if we have to bury it, I can get primary closure. If we've punched it, now all of a sudden that implant's exposed and we can't really cover it up. And the last reason is I'm a CEREC dentist and I'm restoring stuff. If I'm placing stuff 1 millimeter, sometimes 1.5 millimeters or 2 millimeters subcrestal, I need to profile that bone and remove some of that bone so I can get my restorative components to fit. If I'm not flapping, I can't see all of that. So I'm still a big believer in flapping. It doesn't take me that much longer, especially on some of these smaller flaps to do.
So when you're using a guided system, you're creating a flap that you're just pushing it all out of the way.
I'm just pushing it out of the way. I usually just hold the flap open, push my guide on, and then it usually just holds the guide.
And let it sit there.
Yep.
As opposed to suturing it to the cheek.
Yeah. I mean, I've seen some techniques where they literally will just suture it, put the hemostats, and have it hang out, like literally hanging outside the patient.
Oh, that's a good idea.
Some people do that. They take some nylon sutures, and then the gravity from that holds it out. I mean, you can usually get the flap big enough so it just kind of rests on the guide, and then it's not too difficult to get out of the way. Tissue punch, it's easy, it's minimally invasive. That's great, but if the implant's not fully underneath the bone, then we have some issue, and we can't really tell that unless we take an x-ray and then have to go back in there afterwards, or just, there's a lot of stuff that I still am a big fan of. This was a particular patient where you can see I placed it, what you guys think is way deep, but that was also because I wanted to make sure there was 4 millimeters of bone from where my restorative margin is. But when I flapped this was a case I did 3 or 4 months when I went back in. When I flapped this wasn't integrated bone, and all this bone, like bone grafted material, came out like embedded into the flap, and all of a sudden I was like, well, that would have looked like I was plenty deep on the x-ray, but when I flap it, that bone's now gone, and I have to kind of make sure we're still in bone when we do that. You can almost see, like over here, as you can see, like I flapped it, and you can kind of still see that little bone graft that's attached to the flap that I had when I took that implant off. So, where are we at time? 10:15. I'm going to keep going for a little bit. Do you have a question? Okay. So let's talk about this term called abutment swapping. You see, this name keeps coming up. That was the name that was talking about the depth of an implant. It keeps coming up, that guy's name, time and time and time again. So if I see him, I'm reading a research paper on implants and I see his name, I'm pretty confident that he knows what he's doing. Abutment swapping is every time we take off an abutment or a healing cap, we're exposing the bone to the oral bacteria. And they have research that the more and more you do that, the more and more crestal bone you lose. If you start losing crestal bone, then we have issues because threads start to get exposed, and as soon as threads get exposed, then we have some issues. But I'm just like a typical implant, a specialist is putting on the abutment the day of the surgery, and then they're coming back to your office. You take that abutment off, you put your scan body, your impression coping, whatever. That's now 2 times. Then they're coming back in for a final restoration. That's 3 times, and you keep exposing that platform to the oral bacteria. Think of it from maybe like an aesthetic workflow when we're doing an anterior where we're taking on a temporary and taking it on and off. We're adding some, kind of getting this emergence profile the right way. It's a lot of times where you keep introducing and kind of making this biological width redevelop again. So they're highly recommending, and I think if you're placing your own implant and also restoring it, I highly encourage all of you to start taking the final impression at the day of placement. If we're all doing it digitally and there's blood in the way, it really still doesn't affect us, because all we need is that top of that implant, that scan body, that's all the information we need. So in my office, first thing we do is make sure the surgical guide fits. Then I numb up, and while they're getting numbed up, my office is taking all my final scans, all the pre-op scans that I need to restore that implant. We place the implant, we do the ISQ, we do a little bone profiling, and then we're putting the scan body on. And as they're still flapped open, I'm taking the final impression right then and there. Therefore, all we have is one abutment swap or abutment switch. They come in 3 or 4 months later. We already have the crown made for them. Abutment, healing abutment comes off, implant crown goes on. It also makes it become very, very efficient as far as workflows. You can essentially, there's not a lot of post-op visit. There's one post-op visit where we're just taking out sutures, and then we see them in 2.5 to 3 months. Put an ISQ peg on, make sure that ISQ value is going up, and then we have the implant that goes in. It really can be done in 2 visits for implant start to finish if we're replacing our own implants. I always get a little bit of pushback when I bring this up, but it can be done and be done very predictably.
And that's considering you use the correct true abutment scan body post for the tissue height.
Correct, but if it's a 0.5 millimeter a little bit deeper, then you're not going to see it. So I'm using a GH2 or a GH3 for almost all of my cases, and I don't have, and if I'm placing it 3 or 4 millimeters like I had already pre-planned, I'm completely fine, because that either 2 or 3 millimeters is still under that depth of that gum that I'm placing. Kind of, that's where it comes back to start with the end product in mind and a crown down approach to it. If we have all that in mind, it's not, to me, it hasn't been an issue where all of a sudden I'm seeing some metal from that tie base. If we even go to a step farther, when we're doing guided surgery, if I can get that custom abutment or that custom healing abutment, essentially the emergence profile exactly the way that crown is going to be, then that tissue grows that particular way, and then you're having even less interference with it. And that's why I do all of my healing abutments are customizable now through Uris and True Abutment. So you can get that ideal emergence profile, and you're not putting a tremendous amount of pressure on that tissue to get the crown seated like you want it to. We good so far? Am I challenging some of your ideas on how to do stuff? So surgical guides here, there's 2 ways that we can do it. If we're a CEREC office, we can be making them in-house and making them in-office. And we can do it one of 2 ways. We can get them milled or printed. We can get the block, the huge acrylic blocks, put that in the milling unit. Or we can get them printed as well. There's some extra steps and workarounds that you need to do to get them printed. You can do them the same day. They're cost effective, where I can do, the cost of a surgical guide is about $45 to $50 by buying that block. But there are some limitations. You can only do single implants with them. You're stuck with that D2 value. So if all of a sudden you get to a point where you see that sleeve is going to be interfering with adjacent teeth, you're out of luck. You then have to go ahead and either use the other workflow, the CEREC Guide 2 workflow, where you change that D2 value and kind of work around that way and have that kit, or you have to send it to some type of lab to have it made or fabricated. And then as soon as you're doing multiple implants, you're out of luck as well.
But if you're doing printed, you can do multiple teeth or no?
With the CEREC Guide 3, I don't think there is. I'm not aware of it at this point. Maybe some workflows with like CCAT are possible, but not in-house, I'm pretty sure.
Okay.
I don't think you can at this point. And then lab fabricated surgical guides is that we can do multiple implants in one guide. They can be fully timed, so there's going to be a notch in the guide that shows you where you need to line up your implant when you place it, and there's going to be on the implant, the implant holder, my really scientific term. The implant driver, as we're torquing in, will have lines that you need to match up. And then almost all of the lab fabricated surgical guides are going to be printed now with some really high-end nifty printers. So this is me, that implant, and then I'll give you guys this video real quick, but how long it takes me. You're going to see some mistakes I've made. The first mistake right off is I have it labeled 30 and I'm drawing the crown for 29. So you're going to see mistakes that I make, and there's some mistakes that I made on some of the implant surgeries. So I now switched it to 29 and now I'm designing this too. So this is how you can design if you want to design this particular case with that crown down approach and make it in the office. I can't do that with this particular case, but I'm just showing you how long it takes me. So there's kind of this cost-benefit analysis. It takes me more time because I'm doing a lot of the work myself to do it for this. So we first are going to design, and to me this margin on the buckle is really critical because then we're going to want to have that implant 3 to 4 millimeters apical to that implant platform. So I kind of get it in that ideal situation, and I'm looking at the buckle margin of these adjacent teeth. So we're designing the crowns in an ideal scenario, the crown down approach to implant planning. And then we're going to take that file and then export it, and we're going to put it into the cone beam. I probably didn't need to do this, but I was being... So it's called an SS file. We take this SS file and then we merge it with the cone beam and make sure this stitches correctly. Because if these two don't stitch correctly, then the whole guide isn't going to be accurate.
So you're doing this on your computer?
Yeah, this is all done on my computer. So if you have an Orthophos or a Galileos, you have this software in there. It comes with it. It's called Sodexis.
Well, yeah, the Sodexis is
Yeah.
platform that you run the
Yeah.
on.
Yeah.
Okay.
So we're mapping the nerve. I'm finding the file, and I have to, because it's two, I have to import 2 different files. And then this is where we're mapping it and putting like points to like points. And this can become a challenge if there's a lot of metal in the x-ray. You can't get a great stitch, and you're kind of stuck a lot of times on how to move forward. So I'm just making sure, like I'm going tooth by tooth to make sure this 3D model that I just made intimately kind of fits this model, this x-ray. And it needs 3 points to kind of fit. You can do up to 5 if you really want to make sure it fits. And this is where I'm just checking the same thing again. So in this system or this software, the Urus implant is the exact same dimensions as a Hyosin implant. So if you saw, I selected a Hyosin implant because the design and the body and the sizes are the exact same. And then I'm just looking at making sure we get it lined up through the long axis of the tooth. And then I'm looking at different sizes and shapes and making sure I'm avoiding nerves and buccal plates and I'm gonna do, like you can see I've already done some measurements here to make sure I'm like about 3 to 4 millimeters deep. And then I'm looking at buccal plates and all that kind of stuff. And then I know if I'm placing it here, I'm probably gonna have to bone profile it as well. So I know and have a plan when I'm doing these surgeries. I know what to anticipate and what I'm gonna need for my assistant to set up. So 2 millimeters from the buccal plate. And then there's a safety zone as well that's not showing up very well, but it goes around the implant to make sure you're not hitting adjacent teeth and you're not hitting nerves.
So when you say 2 millimeters in the buccal plate, you're really talking about the outside border of the buccal plate?
Yeah.
Okay.
Yeah. And then what I was able to do is now that I'm doing 2 implants, I want these to be as parallel as possible. There's a feature that I can select, make implant of the second tooth be as parallel to 29, and then it'll put it where I want it to. You can kind of see the safety zone here, this little box around the implant. So I'm measuring between the implants here, making sure I have that 3 or 4 millimeters between the implants, and then I'm doing all these other measurements again. Depth, buccal plate, all that kind of stuff. All those measurements that we talked about, putting implants in the ideal position, I'm doing real quick. And then I go around and make sure I'm happy with how everything looks. Now, if this is too much for you, which if you're just getting into placing implants and doing guides, and you don't want to do any of this, you don't have to. You can send your CT scan, your STL file, and send it all to Eurus and True Abutment or Azento, and they will do it for you.
I didn't know these guys did.
Yeah, yeah. So, and this is where we're talking about all these different positions of these sleeves and where to put it. You can make, or if you wanted to do, you're talking about this particular case where it's 2 implants, you would have to make 2 separate guides with the CEREC workflow at this point, rather than having 2 holes in it. But then it's 2 guides, and then you're taking guides off, where essentially my surgery can be boom, 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 boom. It takes time. I don't know why my office always does it to me, but it's always Mondays. I have like 2 or 3 surgical guides, and then I'm waiting to the end of the day. Then my wife's yelling at me for not being home because I'm doing all these guides at night. So that's where it's this, like time is value, time is money. Is it worth your time to be doing all of this? Or would you rather just give it to them to do for you? And then I'm doing more and more where I'm sending it to them to just do it for me. If they have any issues and there's like some questions or concerns, they'll give you a call. You'll get a call from Jessica at True Abutment. You sit down for 5 or 10 minutes and kind of work around some of the things that you want. And that's why I'm just doing more and more of it. And it's also a great, if you're just getting into doing guided implants, have them do the first 5, 10, 15 of them, because you're learning what to look for. And essentially learn what they do all day, every day. Jessica's doing like hundreds of these each and every day. And she'll know, you know what to look for and how to plan particular implants. So like when I was getting in my implants and all my guides in the beginning, I sent them to someone who's doing these all the time, so I knew what to look for and learn. And then we can get these, that's what I just designed, but in that particular case, I was just showing you how long it took me to design these 2. This is a case that we did with Eurus with their guided system, nice and parallel, and I don't have to do any of the hard work. I just upload this to their website. which they'll give you an access code and learn how to submit all of that stuff. So fully guided, fully timed, just to review, proper placement of the implant, quicker surgery, and then prefabricated custom healers, and prefabricated custom abutments if you want to, and then a temporary that goes on top. So those are all the benefits to this fully guided, fully timed system. Where are we at? So I've seen this particular patient like every 2 years because she keeps falling. First, she came in and fell, and tooth number 9 wasn't restorable. She broke it. She chipped 8, and she came in looking like that. We did some extractions at that point in time. She didn't want to do an implant. So we did some bridges, and then she fell again. And then this time, all of the bridge, 7, 8, 9, were all goners. So then we decided to do some bone grafting, and these weren't like buccal plates were gone, and we need to do some membranes. So you're gonna see some pictures where there's recession and stuff like that. We got the implants placed, all parallel, all guided, getting those proper dimensions, 3 to 4 millimeters between. The nice thing about this URUS system is they really thought of everything. There's a lot of systems when we start getting small implants, these 3 millimeter dimensions and 3.5, where they don't have a guided system for you. Like Astra, they have a 3, a 3.6, a 4.2, a 4.8, and a 5.4. There's no guided system for the 3. And those are usually the ones that you want the guided system for, because if it's a 3 millimeter implant, you're threading a needle already, and if you don't have a guide and you're trying to eyeball that, good luck. But they've thought of all of their implants, you can use guided. So we had the custom abutments, custom healing abutments. You can see these notches. It's telling you that's where it goes on the buckle. We can then get good emergence profile. We put the healing abutments on now that the implants are integrated, and we can go and get some implants in there. Now, these are cases where I've learned, like she had a low lip line, so I wasn't too concerned. For me, if they have this high lip line and they're super, super aesthetic, at this point is probably one that I'm punting and giving it to a periodontist to have them do connective tissue grafts and all that stuff. But when it's trauma, low lip line, yeah, she had lipstick on, and that's why all this came out. But to me, no one sees that. You can see from us flapping a couple times, there's some recession there on the canine and the lateral. But overall, she's extremely happy with it. Let's talk about the ideal implant now. We've talked about where we want to place implants and why we want to place them there. Let's talk about what we're looking for as far as the perfect implant out there and the perfect implant system. From a digital perspective, I have some things that I have specifics on that I want to work with in my office. One, these are we want a platform switch. 2, we want a conical connection, long cone to get nice sealing. We want something with good initial stability. We want something that are going to have high ISQ values, because that higher than that ISQ value is, the more stable it's going to be. Going back to ISQ values, the other reason I like it, if all of a sudden at initial placement, I have a nice like 75 or 80, I'm going to shorten down the healing time, and instead of 3.5, 4 months, I'm okay with loading that implant at 2 months. Patient's much more happy, and it's much more predictable because I know what these initial values are. And then if that number goes up at that time at 2 months, then I'm golden, and I know we're going in that correct direction. So that's another reason why I like the ISQ value. And then size and length options. And I say size and length options, especially from a digital dentist, when it's fully guided. So those 3.0 implants, I can get something that's fully guided with the system. And then for me, digital workflows. I want something that has some variability on tie bases that works kind of with the true abutment workflow. Perfect example of where I'm really annoyed right now is that patient was seeing a CEREC doctor in Colorado. All of a sudden, the patient moves. About 2 months after moving, the implant crown comes loose. I get a call saying, hey, I see you're a CEREC doctor. Can you help this guy out and can you fix the implant crown? It's loose. He comes in, and this is a case I'm working on currently. It's a Camlog implant. A Camlog implant, the only thing in the CEREC system right now is the 1 millimeter traditional CEREC tie base. It's a fairly deep implant, and you can see that they've already tried to profile the bone in it. They didn't profile it enough. Well, I'm stuck digitally with that Camlog implant to only use if I want to try to restore it with a tie base with the CEREC tie base. True Abutment doesn't even have that in their system. I was crying to Jay earlier this week saying, why don't you have it yet? And he's like, this Camlog just doesn't want to work with us, or we haven't even been able to figure out the workflows. They figured out almost everything else. But I want things with options. I want multiple scan bodies. I want multiple CEREC scan bodies that I can do multiple things. So now the patient comes in and I have to order specific stuff for that particular implant, and I can't do screw retain. I have to do custom abutments and stuff like that. And then it's this weird, like the guy wants me to do a favor and like not charge him, and I'm like I have to order all this stuff. I'm like, I'm doing you a favor, and my hands are tied because the implant you picked doesn't give me a lot of restorative options, especially digitally, or I have to go take an impression and do it that way. So that's what I look for my ideal implant system. And then a guided kit, with guided kits with options. So let's talk about each of those. Whoops, hold on. I just lost my microphone. I'm good. Okay. So, first thing that we talked about is platform switching. There's a slight indentation at the implant platform on the right that reduces the peri-implant bone loss, and it allows the biological width, and then you can even get bone to kind of grow over that little bevel. That's what the Iris implant system has. Essentially, it's looked at all of this research, and whatever works for all these implants, it's kind of put together into this implant. We have this 11 Morse taper conical connection. So we eliminate the microgap and any micro movements, and it helps prevent any screw loosening as well. And then we have all of these different options within the Iris pylon kit, and we're going to open those kits up this afternoon to kind of show you how to do it and how to work with it. What you need for them to make the system for you is you need a cone beam, and you need to send them an STL file. It doesn't have to be CEREC specific. It can be any cone beam with any STL file. That's what you need to get started. So you need to have an intraoral scanner, and you need to have a cone beam to kind of get this process going. You then send it. They will implant plan it in a surgical design. They will send it back to you to approve. And then they will ask you, do you want custom abutments, custom healing abutments, temporary restorations, all this stuff. And you go in through urislogin.com, and they will set you up, and we can show you at the end how to do it. The surgical guide and custom abutment comes about a week and a half to 2 weeks later with all the pieces and parts that you need, and then you go ahead and do the surgery.
That's basically the Zento kit.
For like a third of the cost.
Okay.
Yes, exactly.
Now the Iris is their brand of implant.
Exactly. And that's what we're going to be placing today, or in the models and all, and doing the sinus bumps and stuff. So you have to use their particular implant to do that. They,
Okay.
so they just like Azento does Astra,
Yeah.
or I think they do Astra or Xive, or the 3 dense Blycerona ones. They are specific to you have to use their particular implant system.
Got it. But they don't do the same thing as the Zento kit where they give you the drivers and this and that and the whole thing.
They don't, because why do you need a new drill? Well, osteotomy drills every single time. Yeah.
Okay.
So you get the kit, and then you use that kit multiple times. And
You have to have their screwdrivers and torque drivers and their whole setup.
correct. Their screwdriver is like is a pretty universal one that I'd say like 80%. It's the 050 hex or something like that, so it's pretty universal. It's the same driver system that Astra uses, so you can use the same torque wrenches as Astra, but it'll come in the kit with you. I call this the easy button. If you really don't want to think about it and doing your guides and planning your guides, hit the easy button, click it on your computer, upload it, all this, and they'll do it for you. So this is just a pretty straightforward case. It was, he had 4 retained primary baby teeth that we took out, grafted, and then we decided to place implants on tooth number 4, implants on 13. And this is where, like in this particular case, I could have gone longer, I think on one side or the other, but I told, and they had planned it that way, just to get as much bone implant in there as possible. I told them, like, let's do matching implants. So then when I can put the guide on, I can go osteotomy, osteotomy, switch it out, osteotomy, osteotomy, switch it out, osteotomy, osteotomy, and then implant, implant. I can make it pretty simple. So these are some of the things and nuances to kind of look for. I think you'll see, so yeah, 4 and 13, and I decided to do 4.5 by 11.5 in this particular case. Now, you're going to see me put this star up every single time. What this is right here is this guide offset allows us to move that surgical sleeve up and down by upwards of 3 millimeters. So you're going to see an offset of 9.5, an offset of 11, and an offset of 12.5. What that does is it allows us to move that guide sleeve up and down, and you're going to see in these protocols when we start placing the implants, they're going to switch it up on you. And if you're not careful, essentially your implant won't be at the placement that you want it. Now you're going to see me screw this up on one of the surgeries. I intentionally left it there just as a reminder that this is, I think, the most important thing that we see. And this offset here corresponds with these little implant drivers when we're placing the implant. This needs to be at the level of the guide. This is 9.5. This is 9.5. This line right here is 11, and this one up here is 12.5. And I will harp and jump up and down a lot more when we talk about this again, because that's the one thing you can't overstep. And then they have the complete system for you. It's a lot of osteotomies. You don't need to use all of them if you don't have to. It's their recommendation, but you can kind of skip some if you feel like you want to skip some here.
I mean, is the offset like an adapter or an extender or all? Or
no, it's just how deep you put the implant at the very end.
Got it. Okay.
So if it's super tight and my guide sleeve can't fit at the 9.5, they'll bump it up and do the offsets a little bit higher so that all of a sudden it's above the level of, and it can fit. And then I just have to place this implant a little bit deeper at the very end.
Okay, so it's like an extender for...
Kind of, but you don't need, there's an extender in this kit, so I don't like using the word extender, but it kind of is an extender. So you're gonna see me, every time I put one of these slides up, you're going to see a star here. And then I highlight this in like a different color than like I highlight the implant. Just as a reminder to myself or to my team of what this offset is. And then we talk about the timing here. So on all the guides, you're going to see this notch here. This notch and these black lines need to line up at the end to get you fully timed. And then that's what allows us to make all of these prefabricated pieces and parts before the surgery. And so you don't have to do some crazy stuff, which you'll see what I was doing 2 or 3 years ago, which I thought was really cool. I don't even need to do anymore. So you can see these lines right here need to line up to make sure it's fully timed. And then talking about the offset again, there's different, there's like the handpiece that goes, the driver that goes into the handpiece itself, and then you're gonna switch when you get down to the last half a millimeter or millimeter or so, where then you're using the actual torque wrench to get it down to the level that you want. And all these numbers correspond with the 9.5, the 11, and then the 12.5, which is the offset that will be on that surgical guide for you.
And this is the actual offset?
Yes, yep. So there's no like extender that you have to put on it. It's just that variation of about 3 millimeters. And that, I've yet to see a case that they can't do and can't design around, just by giving us those 3 millimeters of wiggle room.
Okay. So but there's 3 different ones.
So these are, the yellow is for their narrow. They're 3 and 3.5 because the guide sleeve is slightly different. And then the green is for their other restorative plans. They're 4, they're 4, 5, the 5, and the 5.5, and I think there's a 6.
So, okay, so there's 3 different heights. Are you setting it to a different height, or there's actual 3 different offsets?
There can be 3 different offsets that in the surgical guide they'll give you. The surgical report they will give you.
But when you hook it up, you hook it up to different spots?
No.
Or you change the offset itself?
The offset gets changed by the surgical report. It's just how deep you go. It's literally like,
okay, so
yeah.
you're going by those lines.
Yeah, by those,
That's what I'm getting
yeah,
at.
yeah.
Okay, I got it.
Yeah.
I hate that, you know.
So.
You can never see the lines when you're down.
Yeah, but I mean, this is also raised up. You're not at the bone level.
Okay.
You're at the surgical guide level.
Got it.
So it's much easier to see.
Okay.
So this is kind of the protocol. You're gonna start down here. If you wanna do a tissue punch, great. I haven't used that one yet. You have these top drills, a little dimple into the bone, and then they're gonna have you kind of pick and choose some of these drills as you get bigger and then into the depth.
This is the entire surgical kit.
That's the entire surgical kit. And if you still want to freehand it, you can still freehand it. On the markings, when we actually pull up these kits, there's little lines underneath on here that tell you the actual depth of the implant if you want to freehand it too. So you can use it both ways. You can do guided, you can do freehanded. And then the yellow over here is for the narrow connections, the 3 and 3/0. These are for the normal connections or regular connections. They have what are called bone profiler kits. So the yellow fits into the yellow narrow implants, the green fits into the green, and then they have something called extraction socket drills. So if you're doing stuff immediately, especially on molars, you can actually drill through the guide, like for molars, if you want to essentially section the tooth. These are specifically designed to section the teeth, split it in half, and then you can extract it that way for immediate molar implant. So you're not essentially dulling out your osteotomy burrs. And then these are all the prosthetic, a ball prosthetic driver, multi-units, and the ratchets, and then some hand. These are all the extenders. So if you need more room, you can. And then underneath it, you'll see is where the torque wrench is. The kit picks up, and then there's the torque wrench there. So this particular case, single guide, and I can go back and forth. Sorry, to go back. You can see this is where the timing, where we want to end the timing of the implant on both sides. Over here, we want to have the timing of the implant driver line up when we're putting the implant in to that. This is the day of, where I then took my scan bodies, put them in. You can still see the flaps open. These are my custom healing abutments. You can see the notch that kind of lines up with the notch that was timed. So these can all be made. 2 simple chromic gut sutures. We then, at the patient leaves, we dismiss them. I spend an extra 5 or 10 minutes designing these crowns. This is how the patient leaves. This is how the patient's restored. You can see we're using, I think, GH2 or GH3 tie bases here. Very, very quick, very, very predictable. 2 visits, patient's done with. Okay, we've been going for like 2 hours. So I think now I'm gonna take like a 10-minute break, I think there's some coffee and stuff out there. Restrooms are right out there, and then we'll kind of come back and kind of finish this up with the actual like surgical protocols. So. So it's only when you put the implant in. That's the only variable that you have to think of.
So it's literally like one block around the corner. And that used to be the true abutment building. And now since we expanded, we have to be the second building. It happens to be one that's really nice.
So think of the guide. There's a guide here.
Without the okay.
Don't.
So you only got the bottom
Yeah.
portion.
Yeah.
What's the multi?
Is the top of the guide to the level of the bottom?
How they decide it's 9.5? Why they not get 8, for example? Why they not get 10?
Okay, let me find out.
They picked three numbers: 9.5, 11, and 12.5.
Only that.
That's it.
Let me find out for you.
If you use, for example, 11 and a half, that means
It would be, if it says 11 and a half, 11 here, you need to go, this line right here needs to go down to the guide. It'll make more sense when we start placing the implants.
I see.
And they do that because they need some wiggle room in case there's adjacent teeth. And the metal sleeve won't fit.
I see.
Won't fit between the teeth.
But just to fit the
Just to get the guy to fit.
the guy.
Yeah.
And what is the things you told me? It's tiny, like
The timing?
yeah. What does mean exactly this mean here? This.
So it's the timing of the implant. So the implant is hexed.
Yeah.
So if we're making parts to fit that hex
Yeah.
before the surgery, we need to know where that's going to line up.
That means you put the before the surgery. There is implant you can put it before.
These pieces are made before the surgery is done. So if I want this to fit with the implant that's indexed, this notch needs to the implant needs to come with the timing
Yeah.
at that spot.
Understood. But you don't have another thing. When you make surgery, if you want to use the surgical guide.
A flap?
Yes.
Because I want to see where the bone is,
To see the bone.
the bone level, to make sure my implant's at the right level. And I'm restoring stuff with prefabricated components.
I see.
So if I want to make sure I have enough clearance and my prefabricated pieces aren't going to interfere with the bone, I want to physically see the bone level.
That means that in this case, there is not necessary to use the punch.
You could. I just am I lean towards flapping versus a punch. That's just my preference. If you wanted to do a punch, you could have definitely done it.
To make flap.
Yeah,
I see.
you could have.
Yeah, I see. Understood. Okay, very simple.
Yeah.
on the
Yeah.
handle.
You could have definitely done a punch on that.
Uh-huh.
To me, I just want to make sure we're about 1 millimeter subcrestal. I have enough clearance for my prefabricated parts so I can see everything.
Yeah.
Because,
Open flap, it's easier. You can see everything.
right, you
With your
can.
eye, yeah.
So like all of a sudden, if I get back in there and I think I'm at the right level, I may not be. If all of a sudden the implant's up here, then I have to go back in and then after the x-ray and put it back down there.
Yeah, sure.
You just don't know, you don't know for sure. Like
Exactly.
CTs don't show us everything.
Yes. Usually,
It's pretty close. Like you're gonna see today, when we do this, not all of you, when it says, just because there's some variability with all these models, they're mass produced, there's gonna be where we're gonna go down and we're gonna say, okay, we're doing a 9.5 millimeter offset, and it's still not gonna be at the right level that I'm happy with. And I'm just saying, that's a perfect example of why I wanna flap it.
yes.
Is so I can, like, we can see it.
Exactly.
We don't, I always trust but verify. Trust the plan, but verify it. And if I am not flapping, I can't see it.
To be in safe side.
Right, yeah. It takes me a couple seconds longer. Do you need me to switch? Yeah, are we good? Okay.
I also bought a building.
Yeah.
It's a headache.
Yeah, I know. I know I'm in for the next year. It's going to be a headache.
You're still gonna have your practice on this.
Yeah, so my lease is up in a year. So I'm hoping I can pull this off and not have to like rent back for like a month to month or. You glad you did it?
I'm glad.
Yeah.
But like I had also like a year
Yeah.
and extended over that.
Yeah.
So it was kind of mess.
Yeah. I'm sure it's going to be, especially with like everything's behind schedule or
Yeah.
shipping and shortages and just back orders.
Find the right contract.
Yeah. Because I'm sitting here, I'm like looking at me, it's like the realtor is calling me, the loan officer is calling me. Like you guys can wait.
You'll be happy.
Yeah.
Picture chapter.
You could ask them in the end, like at lunch or with happy hour and stuff.
Yeah.
They'll have the actual costs. I still have a bunch to cover. Let me get. I was gonna get everyone back in. We good? Okay, so a couple questions people were asking me is, could I have done this with a punch? Absolutely. I did a little flap, 2 little mini flaps. I always trust but verify. And you're going to see when we do these. I've done this course enough where all of these guides, I mean, guided is great. We're going to, I'd say 90% of you, when you follow the directions correctly, are going to get that implant at the bone level or slightly below. But I flap because I want to see stuff. And I trust the guide, but I still verify and make sure everything is in the right way. If I'm not flapping, I would have to take an x-ray and do multiple other steps to make sure that my implant's at the right level, that I've profiled enough correctly, that the the scan post is seating correctly, all that kind of stuff that I can just do by just looking and doing that little flap. So yes, I could have tissue punched this. Okay, now this particular tooth you can see is a goner. It's a nice short root and I have plenty of bone, so I'm pretty confident we can get an immediate placement, immediate extraction, and place that implant. So I try to always, for me, and this is where if you're just learning about guided surgery, design and place your implant like you think ideally, send it to them, compare the two, and if you're in the exact same spot as they are, great. And that's just a great way to learn and kind of improve your skills. So we extracted, and then this is my plan. This is the plan that they came back with. We're almost in identical spots with the identical size implant, so I'm good and feel comfortable moving forward. This is the protocol. Now you see here, all of a sudden this number here is now 11. The offset is 11, so now this would have been, right here would be the offset for 9.5. Now we're doing an offset of 11. That premolar is relatively small, and that guide sleeve that we fit into the guide wasn't going to fit at 9.5, so they backed it up to 11. You follow this exact same protocol, what they're recommending all the way through. You just, when you're physically placing the implant, you go 1.5 millimeters deeper. And it's going to line up with this particular line right here. And you're going to see in the surgery, I forgot about it. I placed it at 9.5, and I trusted and verified. I looked because we were extracting the tooth, and I was looking, and I saw I was still a millimeter. My implant was still 1 millimeter taller than higher than it should have been. And I go back in and I torque it down another 1.5 millimeters until we get to that number. So it does happen, and this is where I jump up and down and make sure we put the star here to remember that it's at an 11.
Are you determining your bone density, your D1, D2, D3 bone?
They will determine, they give you in this surgical guide, in the report, they will give you an estimate. I just had one where they said it was like D3 or D4 bone, and so I went to soft, and like 2 or 3 turns had already torqued out, and I was set at like 25, and I'm like, okay. So I tried normal, I got a little bit farther down, took the implant out, and in that particular case, I had to go all the way to the hard bone setting.
So they're getting it off the scan.
They're looking at the scan and looking at the density of the bone based off of that. So they give you a ballpark, but then it's still feel. Like to me, when I've had an implant fail, it's usually that I've torqued it too much rather than it, like my spinners usually integrate, I just have to let them be. Just in my experience over the last couple years of placing implants, it seems to be the ones that I torque too much are the ones that fail. So I always would rather, I don't like spinners, but I would rather have that than something and kind of back it out and then make a bigger osteotomy.
Did you record in your head those torque values that failed?
Yeah, one was super high, and looking at hindsight, it was probably one of my first 10 or 15 implants I've ever placed.
Like over 35?
Yeah, okay. It was way over.
Okay.
I'd say it was probably 60 or 70, and I should have known.
Ooh.
Yeah.
Okay, so you wanted a interior, put a
yeah,
temporary
exactly.
on the whole thing.
Yep.
Okay.
And those are ones that I've now learned. Yeah. But worst case, I have yet to have a spinner fail if I buried it and had to come back later. Right. I always feel bad, like I'm always hesitant, but and then I'll put an ISQ and it's like a 50 and I'm like, crap, well, we're burying it, and then they come back and the numbers are usually huge. That's like 75, 80, 85 when you respect the biology and get primary closure. Nice thing about yours too is all of them come with the cover screw. It's included. You don't have to buy them separately. It's going to be in the top. When we get to it, you're going to pop open the lid and it's going to be top in there. The healing abutments are separate, but the cover screw is always going to be there. So remember, you're going to see me screw it up in this video. So in this particular protocol, they have these socket drills. This is if I want to essentially section the tooth and then take it out. This is a one-rooted tooth, so I don't know if I use these or not, but I really didn't need to because it's a tiny little premolar. So this is just kind of the protocol and the animation, the socket drills if you want it. So you can see the socket drills go down to the apex of the tooth. They don't go any farther because their primary goal is to just destroy and loosen up the tooth itself, the remaining tooth. So you have 2 socket drills, then you have these little, that's when you start getting the osteotomy drills for it. And you're going to just see deeper, smaller, then they're going to widen it as you go. And then the implant and this animation goes all the way to the second line, which is that 11 millimeter offset. So we just animated the surgery. Now you're going to see me do it. So I don't know about you guys. I have a piezootome. I use it a fair amount. If you don't know what a piezootome is, it's like a little jackhammer. You're going to see me use it for all my immediate cases. I'm popping off the crown first. But for all my immediate cases, I want to make sure I don't blow out any plates on accident. So it's just like, it's like a power elevator. It's like a little jackhammer, a lot of saline solution that comes with it. And you just go around, pump up and down like you would do an elevator, but up and down and around the tooth, and it really starts to wiggle the tooth out of here. So you're going to see me. These are all, I apologize, this is not the greatest video quality. It's my assistant on my cell phone. But you just kind of go around, pump it up and down, and it helps allow you to create a little groove to really get your elevator in there and pop these out pretty quick. The only editing I did on these videos is I just sped it up 2 times. So these surgeries can be done fairly quickly.
So now, if this was a molar,
yeah,
and then right up there with your socket drill,
you could.
You would take your, but basically you have as a hole.
It would be a giant hole, but then it's just a way to, like a way to section the tooth, and then you can pop out the mesial and distal roots.
And you just put your elevator in there.
You could do that too.
Collapse it in there.
Yeah. I think all the videos I'm showing today are like in the 7 or 8 minute range. Double it or triple it, and that's essentially how long it takes with these guided surgeries. There you go. Secure out the socket, irrigate it real quick. We're going to get our guide on now and make sure it fits, make sure it's nice and stable, and then start doing all those procedures, those osteotomies that we just talked about. Or sorry, yeah, osteotomies that the surgical protocol recommends. I always laugh at these videos because they're sped up. I was like, I wish my hands worked that fast. So guide goes on, and then osteotomies real quick. That's actually, I think, I actually did use the socket drill. I didn't need to. I guess for completeness sake, that I'm following the exact same protocol as what the surgical guide recommended.
So right now, do you have notches to line up, or is it
Nothing. The only time you need the notch and the only time you ever need the offset is when you're placing the implant.
Okay.
And what you're doing is you're just going straight down to the hub. You're going to see this little ledge in the osteotomy drills. Just go all the way flush till you can't push any further. That's all you're doing.
It just stops it right there.
It'll stop it. You can't go any deeper. No, these are all done. If you're going to be using the Urus system, you either need to use in their guided system, you have to use their guide. you can use, if you want to make your guide yourself, then you have to use their CEREC Guide 2 kit, which then you can still do it. You just have to use a different kit. To me, when it comes with like immediates and it's just like 5 or 6 extra steps that I have to think of. Like I have to physically, manually remove the tooth, extract the tooth. This one I couldn't anyways because of the offset. The in-house lab, because I can't move really the sleeve up and down unless I had that CEREC Guide 2 kit to move it up and down. It was just like when it gets to like 3 or 4 things that I have to think of extra, I'm like, I'll press the easy button and make them do it. So this is where I'm going down to the wrong offset.
Because you're moving so fast.
Yeah. And you're gonna see, I also did an ISQ, and I got a pretty low ISQ, and I was like, that's strange. So you can kind of see it, you can see the top of the implant if you looked really quickly there. Yeah, it looks high. And I didn't figure it out until all of a sudden I got this ISQ number that was super, I think it was like in the 60s, low 60s, and I'm like, something, I have plenty of bone here. So that's what the penguin, so it's 65 upside down. So I take it off and then I look and I'm like, yeah, I have to go deeper. So I put it another 1.5 millimeters deeper here. So this is what the ISQ peg and the wand looks like. Just a little peg that you put on there. You're gonna see me come back with a guide. And I'm thinking to myself, what am I doing? What's wrong? Troubleshooting it. See, I even scanned it and went too far. I went 2 or 3 steps too far, and then I probably looked at it and I was like, something's not right. In an ideal scenario, the pre-op scan should have already been done. I did a couple things out of what I don't normally do. I was getting too nervous filming myself.
Are you in Philadelphia?
No, so I went to undergrad in dental school back in Philadelphia. I was born and raised here. You saw the practice that my parents' practice that I was part of. But we didn't have a football team. During the 8 years that we were back there, it was like when we were going to like the NFC championships and the Super Bowl. And like football is a religion in Philadelphia. Like everyone, like it takes over the entire city. So, so this is where I'm putting the guide back on. And then I'm going to torque it down another 1.5 millimeters. All of a sudden the ISQ values go up. The bone level is at the right spot. But those are the things to just think of and why I highlight it now. So I put the torque wrench back on. We go back a little bit deeper. I get the timing right, and everything looks great suddenly.
You don't need to rescan, right?
I do need to rescan because the depth of the implant has changed by 1.5 millimeters. But the scanning that you saw me doing, I actually didn't put the scan post on. I was doing all of the other catalogs, the bite, the lower, the upper, and then now I put the ISQ back on. You're gonna see like it's in the 70s now. I feel more confident about that. There you go. You didn't, yeah, 73, so it went up like 6 or 7 points. And now you're gonna see me put the scan body on and scan it. Yeah, and I'm using the GH2. Sorry, to go back to the Philadelphia story, just become a religion. So like, we'll see how I feel Sunday afternoon after Tom Brady's. But the last time we played Tom Brady, I was very, very happy in the playoffs because that's when we won the Super Bowl. So I'm actually on the season ticket waiting list.
Oh, really?
I've been on it for like 20 years. I think I have another 20 more years to go because just one of my good friends who was a year ahead of me in dental school just got his tickets, his season ticket waiting list. So hopefully I'm not too far behind him. And I would just we have, I mean, all of my wife and my wife met and I met back there. So we still have a ton of friends. So we'd probably go back for a game or two each year.
But if you got season tickets, you would fly back?
I would fly back for like a game or two, and then I have enough friends, and they sell like hotcakes. Like these tickets sell so quickly. And then I did a little bit of bone grafting. I would completely do, this was about a year and a half, 2 years ago. I would completely not use the material that I'm using right now. It's called Ossix bone. It's like a synthetic bone. It was like this packable sponge. It didn't really work great in this particular case. In a couple other cases I've used. I would go back to some cortical cancellous and mix it with PRF. And we're going to talk about a little bit PRF in a couple minutes and kind of get some nice sticky bone in there instead. And you're going to see a case where we actually did a couple weeks ago on how we grafted it. And then we're just going to suture. And then we get that case like that. That's the restoration. And then let's talk about now why I think the timing is really critical. I'm going to call some what I call old school. I'm going to do some new school, which I did like 2 or 3 years ago with the CEREC machine, where we took impressions and scans at the day of delivery, or at the delay of implant placement. And then what I call newer school now, which is like everything can be done before the surgery is even done. So if you're doing non-digital, there are a whole bunch of steps if we're talking about an aesthetic implant. I mean, impressions and then stone models, or you're going to freehand the temporary in the mouth. We take another impression. We need like these custom impression copings to get the proper emergence profile. That's a lot of work, especially in the anterior for an aesthetic case. And then we can finally take the final restoration after doing all of this stuff. The digital aesthetic workflow is that we take a scan, preferably at the time of the surgery. We can make a temporary crown while the patient waits. We can then scan again, and then we can go to the final restoration. So we can skip a lot of these steps by just doing it digitally. Or we can get some 3D printed models if you really want to get some other fancy stuff. And this is what I would call the new school, and then there's a newer version. So this is a particular case that I did, like I said, 4 or 5 years ago, where he comes in, he's broken off tooth number 8 at the gum line. I looked at his bite, and before I re-cemented that post back on temporarily until we could take the extraction, I was like, his bite's okay. We can actually make a Maryland bridge as a temporary instead of doing the flipper. So I go ahead and scan. He comes in as an emergency visit. I scan him real quick. I can then make a 1-wing Maryland bridge and then make the Maryland bridge so the day the tooth comes out, if we can't immediately load that immediate extraction and immediate placement, and we can't go all the way to immediate temporization, I have a temporary for him. That temporary costs me an implant, a CEREC EMAX block. It's like 35 bucks. Would I rather take impressions, send that out to a lab for a flipper that's going to cost me a lot more? And is the patient going to be happier if I can do a Maryland bridge? Absolutely. So just kind of keep an eye on that when you're seeing these immediate cases. Can you do a Maryland bridge? So I scan the implant at placement, and I make either a a temporary crown, or for me, you're going to see I make a temporary crown. It fits. It looks great. And I cut it off because the doctor, at this point in time, I wasn't doing implants. The doctor said it wasn't good enough for an immediate temporization. We can then scan and then do the restoration. And I liked my temporary crown enough that I actually used the digital design of that for my final restoration. So there's a lot of skips that I'm stepping that I think are really cool here. So this is my Maryland bridge design. A little bit thin here, but how his occlusion was, I can get away with it. Tooth is extracted, implants placed. He comes over to me immediately after the surgery to place this, and I put this scan body on. This is before true abutment as well, or I would have done a different scan body here to get a little bit higher above the implant platform. I then in about an hour, I design this temporary crown, mill it, cement it on the tie base, and then I try it in. You can see with the placement and how it was, I'm gonna have to do a 2-piece custom abutment here. But I'm looking at this saying, hey, that's a pretty good shape, pretty good color, pretty good emergence profile. This is how I want the final crown to look. I can't load this right now, so I take that pencil line and I go back into my lab with a high speed and just cut it off at that pencil line. And now I have a custom healing abutment.
Interesting.
I then now have the Maryland bridge. What?
Clever.
Yeah. So now aesthetically, I know that, okay, I can almost go straight to final. If that crown looks good, I'm just gonna make custom abutments in the pieces underneath and cement that crown over the top. I then can now cement the Maryland bridge that I already had made, and he walks out in about 2.5 hours with this. It doesn't look great up here. That's because that's where the custom healer and the temporary abutment, or sorry, the Maryland bridge doesn't it's a little bit wonky, but the patient's significantly happier with this than with an actual flipper, because there's hardly anything on the lingual. Then we wait 3 months, it's integrated. I already have the design for the implant. We then make a custom abutment out of Emax. This is pre-op, kind of what it looked like. This is him day of delivery of that implant crown. And then you're gonna see a couple years later, I was able to take it. That's, I think, day of delivery. And then you can see the papilla start to fill in here. And this is a couple years after.
Nice.
Fun little workflow that you can be really, really efficient with. And the patients don't really realize what they got compared to what the old school approach of multiple visits, making temporaries and all that stuff. So, scan and implant placement, temporary crown that I turned into a custom healing abutment. And then we can go straight to the final restoration. Compared to what I call the old school, which is stone models and pouring up and freehand, all that stuff. I thought that was cool. Then Azento and what True Abutment has come out with, where you can go straight from an STL file plus a cone beam, and they'll give you a custom abutment and a temporary crown, all prefabricated and ready to go. So it'll all fit if you obey and follow all their rules. And then final restoration. So this patient we literally did like 2 or 3 weeks ago. Had a bunch of work. Aesthetically, there's so many mishmashing crowns and so many implants super low lip line, so I really have no aesthetic concerns here. This is where you put everything together with True Abutment and Urus and their workflows. This is the epitome of that in this particular case. So this case, we're gonna be threading a needle. We're not a big space, so tooth number 7 is already small. This particular tooth, it looks like it's number 6, but it's actually tooth number 5 in tooth number 6 spot, and there's 2 roots, and one of the roots is like coming right into the spot that we need on the lingual. So I can't place this implant too far lingually. I have to place a little bit more buccally, and when I do that, my screw access hole is literally coming out almost the facial of the implant. So there's that where I have to get True Abutment involved. They're gonna have to make me a custom abutment to get that seated so I can get an implant crown on there. We're then threading a needle where I need to get a 3.0 implant. I'm not aware of any other company or implant company that has something that's guided for that small of an implant at this point in time. This space is already small enough, and now they're gonna be adjusting the offset so for my guide sleeve to fit. So we literally have 4 things that 3 or 4 things that I normally can't do that they've figured out workarounds for me for a digital implant office. And it kind of all comes together with this particular case. You're gonna see guided implant on a 3.0 implant. The offset's 11, so it's gonna be a little bit higher here. And then they have some of these flat drills in case I need help getting that tooth out. In this particular case, I had my trusty piezoatome. And in this particular case, I told the patient, you're more than likely gonna get just a custom healing abutment. But if I make the temporary, and then I need to turn it into a custom healing abutment, all I do is the exact same thing, and I just cut it off with my high speed at the end. So I tell them to make me a temporary with a custom abutment to fit. But I know in my head, if that doesn't work, I just can cut it off. And then remember this offset of 11. So, extraction again with an immediate placement and an immediate temporization. I got an ISQ value right at like 69, which is right on the borderline. I trust this patient, so I went ahead and actually did a final delivery on it, or final temporization and immediate load, and then just really significantly cut it down. This tooth actually took me a little bit of time to get out. There's like a little bit of a curve at the apex. So this one probably takes me a little bit longer than I normally do on an anterior, but and had to work on it a couple times, but we eventually get it out of there. And this is where you really have to sound when we're looking at the CT scan. I don't have a lot of buccal plate, so I have to be very, very careful that I don't break that off. Because if I break that off, then nothing's going in. All that's going in is a membrane with some bone.
So even if you break the buccal plate but leave it in place?
I'm not placing an implant. Because there's some like, even like, I don't know if there's what's called an extraction shield technique. Have you guys seen this yet? Where they will cut the tooth and then leave about 1 millimeter or 2 of the tooth intact. Very, very tricky, very, very delicate. This is a case that you could probably try to do that on to save more of that buccal plate. I'm not experienced enough to do that, but that is a technique that's out there where you are intentionally leaving about 1 millimeter or 2 of tooth structure.
Really?
Yeah.
I attempted a few times. Very difficult.
Yeah, super technique sensitive. Like I know really, really experienced surgeons that have like, I'm not gonna try, I don't try it anymore. Just because like, there's like all these specialized tools and techniques. Come on, little guy, come out. There we finally go. So guide goes on. We start doing our osteotomies here. Following the protocol which I just showed you, remembering with the offset of 11.
What's that socket drill for?
Socket drill, it's usually for molar teeth, immediate molar teeth. So if you want to essentially put the guide on and drill that down, it'll essentially sections the tooth in half for you, and then you wiggle out the mesial and distal tooth. It's just a way, so like there's a lot of guys that I know that just use their osteotomies and do their osteotomies through an existing tooth. It's just a way that you don't, it's a different material, so it doesn't dull your osteotomy burrs out.
Could you have used it in this situation?
I could have.
Before the...
Yeah, I'm just, I just feel like if it didn't go all the way down to depth, I'm then chasing an even smaller piece. But yeah, I guess you could have. It's primarily used for molars. And then the other thing with guided surgeries is that you technically can't get a lot of irrigation down into the osteotomy because this guide's in the way. So always just make sure to irrigate a lot, and then before you place the implant to irrigate it, curette it, make sure everything's out of the way. So a little technique that I use is in these particular cases, if I want the bone graft from the right spot, all of a sudden not the implant first, is I'm actually putting my bone graft where I want it. I'm going to put the guide back on, and then my last osteotomy burr, I'm going to go in there super slow in reverse just to push all of the bone out into where I want it to go. And then I'm going to put the implant in. Because all of a sudden, sometimes it's on immediates, it's tough to get the bone down into the spot you want, especially when it's narrow like this. So I just did some PRF, did some sticky bone. I go super slow in reverse with my last osteotomy drill to kind of push the bone out into the spot that I want, and then I'm going to place the implant.
So you place the bone first, osteotomy drill, and then the implant.
That's what I've.
People place it,
The implant first, and then try to pack it around.
Yes.
You're going to see I do both. Then I try to pack more bone around. But this is a tight little area.
Because I've also heard people say that they only put the bone on top anyway to keep the soft tissue from migrating. I mean, I used to do it first, but,
Yeah.
but if you don't do what you said, you get bone piling
Right,
up.
everywhere. It just, I don't know. That's a little trick that I've tried to use. If it works for you, great. If it doesn't, go back to your way of doing it. And then we're going to go ahead and kind of torque that implant in place. And then we're going to make sure that the timing is correct. I had a decent torque value, I think in like the 40s. ISQ value, I'm not surprised, was still a little bit on the low side, in like the high 60s, just because there wasn't a lot of bone at the coronal 1/3 where the tooth came out. And you're going to see me kind of pack a little bit more bone in this area. But then, like, if you're packing it afterwards, then you're going to get bone fragments down into the implant, and then you have to clean out that, and then you're trying to put healing abutments on. The bone gets everywhere. So
The PRF, you have to make that in advance. You do that in your office, you have to draw blood.
yeah, so we do it, we get them numbed up, and the next thing we do is we do the blood draw. And then you'll see the system that I use. I'm doing the ISQ value here. We then have, we're running short on time, so I'm going to start jumping ahead here. But then this is what it looks like at the delay with everything prefabricated. So you can see I shortened it up to make sure he's not in occlusion. You can see just all of the different colors and that he doesn't have a high aesthetic demand. So this is like the epitome of what you can do with cases with this system. So this is where you can start doing advanced stuff pretty quickly by having all these pieces prefabricated. And then we're going to give this about 3 or 4 months to heal. If that ISQ value is going up, we can biocopy this crown and make it's going to be a cement retained restoration because of how I had to place the implant. The screw axis hole is actually coming out like here, even with the custom abutment. So we're going to kind of switch topics real quick and start talking about internal sinus bumps and then the other kit that is all that we're going to play with this afternoon. Internal sinus bumps, we need at least 5 millimeters of maxillary bone. So just kind of remember that. If you really want to push it, you could probably do 4.5 to 4. But if you're doing it internally, 5 millimeters. And if you're going to be doing internal sinus bumps, get ready to things are going to perforate. It's going to happen. And the research shows that about 25% of, even with experienced surgeons, 25% of sinus procedures will perforate the sinus. And that sinus bumps with the simultaneous placement of the implants are still very, very successful. Not as high as the 95 to 98 that most implants are on, a little bit less, kind of at 90 now. Now, the type of sinus perforations that are out there. There's going to be the class 1s, which if you're doing an internal sinus bump, that should really be the only thing that you're seeing. Because your implant and your osteotomy, you're probably only placing a 5.0 implant anyways. So you're going to be in this category. These class 2s, 5 by 10 millimeters, and these class 3s, 10 millimeter plus, are big ones. But if you're doing internal, there's no way it's possible to get a tear bigger than essentially 5. So these class 1s are no collagen membrane is needed. If you want to, and you have a resorbable membrane in your armamentarium, throw one up there. There's no harm in that. Maybe just to your pocketbook since you weren't planning on it. Put a PRF membrane is highly recommended. So do the blood draw, centrifuge it, get your little boogers and your boogers and kind of turn it into a membrane and kind of pack it up there. Even if I don't have a perforation, I'm still using PRF on my sinus bumps. You can still place the bone graft and you can still place the implant. And we know, or most researchers say that the sinus membrane will, when it closes, will also create some bone while it does it at the same time. If we're talking about class 2, which hopefully we shouldn't even have if we're doing internal sinus bumps, that's where they're recommending some type of resorbable membrane put up there. You place the bone graft and then you need to do the implant in another visit. These are usually for, when you run into this is where we're talking about lateral sinus windows, when you get that big of a perforation. And then I joke, if you had a class 3, 10 plus, it's not, don't ask me. Because I'm not doing that. You're gonna be sending it to an ENT and you're doing lateral stuff, and I'm not, with these kits, that's not what it's designed for. That's for another lecture taught by someone else at this point. This is the paper that I just used all that information from. It's from like the Journal of European Implantology. Great paper that kind of goes through all of those things I just talked about real quickly. So how do we do PRF in my office? Is we do the phlebotomy. We want to get it in the centrifuge within 90 seconds. And then we can do several different versions of it. We can turn it into membranes. We can do it into plugs. We can cut it up and then mix it with the bone graft to create sticky bone. Let's talk about PRF versus PRP real quick. There's the plasma versus the fibrin. Have we done PRF here before? Okay, no? So there's two ways to do it. We do the blood draw, we put it through a centrifuge, and if you put it through a centrifuge for a couple minutes, you can get this liquid that you can harvest and take out and then mix it with the sticky bone. Pretty quick, it's a couple minutes. The analogy that I heard from this one researcher, and all this research it's coming from is from a company called prf.edu. He's a dentist, went to Switzerland, and essentially did a master's all on PRF and how we use it in the dental industry. Because it's a liquid, it gets broken down by our bodies pretty quickly. And he says it's like a downpour. All of a sudden, the water comes in, or like if we're talking about farm, the water comes in and then washes away pretty quickly. That's the plasma. The fibrin is you have to centrifuge it for about another 10 or 15 minutes, upwards of 20, allow it to clot, and then you get these big boogers that come out of it. And it takes the body a lot longer to dissolve it. So therefore, it's like drip irrigation, where it takes the body longer to break down. But when body's breaking down, it releases all these nutrients for a longer period of time. So he highly recommends using the PRF, the fibrin, rather than the plasma model of things. And then what we're looking for is all the white blood cells, all of the growth factors are in this top slug portion of the tube that we want to take out. And it doesn't necessarily help bone grow, it just helps the body heal quicker. Because it's our own body, we're in a concentrated form, essentially our own body's white blood cells, immune system, allowing us to heal quicker. And it's all about blood supply for healing. So if we're taking the blood that we're using and putting it in a concentrated form in an extraction socket, that's great. And the reason for that is, where does the blood supply in the jaw come from? One, it's the periodontal ligament. Well, if we're taking a tooth out, the periodontal ligament's gone. The next step it's going to come from is the periosteum. If we're doing a flap, the periosteum is gone. Then it's going to be coming with the bone itself, but that's not a significant amount. So if we can take the body's own essentially good stuff, and put it back into this extraction socket or bone grafting area, we can heal a lot quicker and a lot more predictably. And that's what we're looking for. We're looking for all this stuff here on the bottom and giving the body and that trauma that we just induced by ripping that tooth out or putting that implant in, and allowing our body to heal as best as we can. And then there's all these like VEGF, platelet-derived growth factor that's in this white blood cell. They're even like selling this now on its own. It comes in like little drops. You can put it on your bone graft, and then it helps the bone matrix proteins to allow it to grow on these people that I see online with like these huge bone grafts that look amazing. They're using like all these little growth factors and throwing it into the bone. So we put it in a centrifuge. We take this booger, we harvest that, and then we can do multiple things with it. Like I said, the things that we're looking for are the VEGF, which is angiogenesis. We want blood supply to grow back in there. If we get blood supply, things heal better. And then we get the recruitment of all of these other things, the PDGF, platelet-derived growth factor. Then we'll call all these bone matrix proteins and allow it to heal and fight off infections. So there's two main systems that I know about when we're talking about PRF in the dental industry. There's one by BioHorizons, and what it does is the centrifuge is at an angle like this. And the theory behind this company, and this is the guy that was from Switzerland, is that if you get the centrifuge and get these vials to go completely horizontal, you can get a much higher concentration of all of these white blood cells that you want. So I'm going to spin this, and if you in the centrifuge here, you're going to see when you spin it, the vials swing out and become more parallel, so you get a better concentration of the PRF. We go ahead and spin this for the protocol that they recommend, and then you can get these big, huge boogers that we talk about. We can do a couple things with it. One of these boogers, what I did is there's this shield that goes on top of it and flattens these out, and you can turn it into like a membrane like this. And then when we're talking about sinus lifts, we can shove that membrane up into essentially the sinus floor, and that can help seal class 1 sinus perforations. I'm still throwing that up on any type of sinus bump I do just to help with the healing. We can then take this with scissors, chop it up into like little, my assistant always calls it pokey, and mixes it with our bone graft. And then you can get these big, huge bone grafting particles that are really nice and packable, and they stick so it doesn't fly every which way. This is a particular case where I like this huge sinus, and there's an internal resorption. It's not the greatest picture here, but there's a pretty big, like 3 or 4 millimeter sinus tear, like right in this particular area. So we're able to get that tooth out, put the membrane up, put the sticky bone up there, and then push pretty hard, and we can see we actually got, I'm hoping with this particular case, we're able to actually avoid doing a sinus lift just by getting a bunch of that bone and creating a seal with that sinus perforation. We'll see how it ends up healing. This is in the healing phase right now. But you can kind of see some growth as we're trying to push that membrane up. But these are some things like this particular patient, like he was like, yeah, when I had my wisdom teeth out, I had some horrible sinus complications. So he knew what to expect when we're taking his tooth out. And then this is where the kit comes in handy. I'm going to kind of skip this real quick because we're a little bit late on time, and I'm going to show you some of these surgeries here real quick and the outcomes. But there's a protocol that they're going to walk you through to get you to that point. It's a combination of they plan these initial drills up to about 1 millimeter short of the sinus, and then we're going to slowly work our way up until we break through the sinus floor. And you're going to see these little condensers that they want you to feel for the sinus first before you start putting bone in. Then, once we have the bone in there, we put the bone graft up, and then we slowly start widening the osteotomy until we're ready to place the implant. And then we're also going to use this hydraulic sinus elevator. So there's water or saline that we put this into the guide and then push with a syringe of saline water to try to help relieve and kind of tear the Schneiding membrane away from the bone so we can get the bone graft up there. And then once we get all of that done, then we can finally put the implant in there. So this particular case came in and like failing root canal, failing root canal. You can see all the abscesses here. We have a wisdom tooth here, and you can see just how crummy the sinus looks with all the kind of the inflammation here. We take these teeth out, and you can see the difference in the sinus by just getting all those periapical lesions out of there. I have about 5.8 centimeters of bone, so this is a really good candidate for an internal sinus bump. We send this all, the CT scan, the STL file, we send this to True Abutment, and then they come up with a design. So we're gonna do a 5.0 implant by 10. So I'm going from a 5 millimeter bone all the way up to 10 millimeters here. It's a pretty aggressive sinus bump. I would probably, in hindsight, have probably used an 8.5 millimeter implant, especially if I'm doing a 5. But I wanted to try things out and see how we go. So this is the protocol that we talked about. Initial osteotomies to the floor of the sinus. Once we get these sinus burrs right here are not end cutting at all. We also need to slow down the RPMs on our motors to about 50 to 100 RPM. Super slow because we're being very, very careful to not pierce that membrane and create a perforation. We do some hydraulic pressure. We do a little bit 1 millimeter deeper to see if we can get to that see if we give that give and we have that feel that we've gone through the bone into the membrane, and then we start packing the bone, and then we start widening the osteotomies, and then we finally get to the implant placement. And then remember again, offset. When we're getting back in the back, it's almost always an offset of 9.5. Just because we're usually doing molars when we're doing sinus bumps, there's more room for that guide sleeve to fit. So here's kind of a video. Yes, I'm doing a flap again. In that particular centrifuge, they have a particular protocol. I don't remember it off the top of my head. It's pre-programmed in the machine, and I just click yes. It varies. It's definitely different than the BioHorizon. I'm forgetting the name of the actual PRF machine because it's a horizontal, completely horizontal centrifuge. It's actually much slower RPMs for whatever reason. That's what they think works the best. If you end up buying that particular centrifuge, there's a great online course that walks you through everything. You learn a lot with it. And then I know he does courses too. It's Richard Myron, and he's I think in Tampa or somewhere in Florida. And he still does online. He does in-person courses where it'll teach you to do the phlebotomies. I told my staff you're being guinea pigs for like my first 5 or 6 phlebotomies, and I just started practicing. And then the first one I did on a real patient, I sit down, and it's a nurse, and she's an actual trained phlebotomist, and I go, oh great, I better get it on the first one. And she kind of walked me through it, and we got it on the first try. And there's some cases where we don't get it. It happened. I mean, especially if you get like there's a vein light, and you see these veins that are like tiny as all heck, and I'm like sometimes I'm like, I'm not even gonna try because I'm gonna know I'm going to poke you a couple times. Try the top of the hand. And sometimes all you really need is like a half a vial. And you get a nice little plug. If you're doing a smaller bone graft, that's really all you need. So this is where I talked about, we're going to slow down the sinus drill to really, really slow when we're kind of getting up into that, close to that sinus, so we don't go flying into it. And 1 millimeter increments deeper as we go through each one. And then you're going to see me here where we take these packers, is that you're going to feel like you hit bone, and then all of a sudden you go deeper and deeper, and all of a sudden it just gives, and it goes all the way down to the collar, and you feel like you finally have broken through that, that plate. This is where the hydraulic pressure is. If there's a whole bunch of give, it means you haven't broken through the bone yet. If there's a little bit of give, it means you've gotten through and you're pushing that sinus membrane up. Yeah, yeah. It's 25, the research says 25%. So it's gonna happen. So this is where you can see I'm trying to pack it and it's not going anywhere. I think we do a 1 millimeter longer sinus drill, super slow, and you have to put a little bit of pressure on these because it's not end cutting and you're going up against a little bit of bone. And hopefully you kind of break it and you actually move that whole bone up into the sinus. That's the greatest bone graft in the world. You're going to do some more through the guide. So you can see there's a little bit of give there, and I take the saline back out. And it's funny, sometimes all of a sudden like the patient will be like, oh, they all of a sudden feel it when you get into that spot. Oftentimes I'll switch it now, and then I've done these a bunch, is I will do that little bone packer first, and if I feel like it broken through, then I'll put the bone. Because if I'm putting bone graft in there and it's not going through, you're going to see me pop in one of these if my hand gets out of the way, I feel like I pop through. There. You see all of a sudden I pop through. I've broken through that cortical plate, and now I can start pumping bone up in there.
So you don't recommend this unless you do the whole PRF thing?
I was doing this right now. I'm doing this before I did PRF. Okay. I brought PRF on about a year ago. I was scared. I was like, I don't know. I'm used to needles inside the mouth, not on people's arms.
So do you find it's more successful?
I have. In post-op healing, all that kind of stuff. So now I'm just kind of packing the bone in there. We're going to widen the osteotomy and then place the implant. So these, you can go back up. All you're just doing is now widening it. You're not doing anything depth, because depth-wise you don't care. You have your bone grafting material up there. I mean, this is where I think keyless, like if you have all this stuff in here and then you're at a key and then another hand, you have like the assistant's holding the guide, you're holding the key, it's just a whole bunch more stuff in there. And then there goes the implant. And then you can see the notches. So we're doing 9.5. So this is gonna go down a little bit. And then I'm gonna stop it. And then we're gonna go with a torque wrench the rest of the way. And then we just want to make sure the lines line up, and then that's where we have the custom healing abutment ready to go. And then the pressure is really going to be on me today because we have these models with sinuses that we're going to try not to perforate. And I'll do it first, and hopefully I don't perf it in front of you all. And then we're going to do some ISQ values. Those ISQ values are usually a little bit lower because you don't have any bone. But that's What number did I get? 79, 74, not bad. So good initial stability, good ISQ values, and then we're going to be taking that ISQ number when we're going to be restoring it or before the restoration goes on. So before, you can see a nice little dome where we got the bone up in that area. Then we're going to place the implant. You can see the CT scan where you see nice little bone and dome around where we place the implant and kind of all the dimensions. And then we restored it and kind of time of surgery, design, and then final. This is a particular case. So I've added, have any of you guys seen the Densa burrs? No? Yes? No? There's a lot of no's. So Densa burrs are a company that I've kind of added a little bit to this repertoire if I'm going to be doing some aggressive internal sinus bumps. They're normal osteotomy burrs if you go forward. If you put them in reverse, what it does is it sends the bone out and densifies the side of the bone, but will also shoot bone up. So if you want natural bone grafting, essentially use this system and it'll start shooting the bone up here for you. So what I've done is when I get to this point and I've broken through the sinus, I use this system. You don't need to buy the whole system, where I will then use smaller than the 3.9 and the 4.3 Densa burrs and put it up and kind of pump it very, very slow RPMs, just like you were doing it with the sinus burrs, and it'll slowly widen the osteotomy and shoot the bone up into the sinus. So you're going to see this particular case. Not a lot of bone here. This is probably like 4 millimeters. I ended up getting a sinus bump done not only for tooth number 3, but also a bonus for tooth number 2 as well. You can see all this bone. This is one of the downsides of when you're doing an internal sinus bumps. Once you've put the bone up there, you have no idea where it's going. It's just wherever the membrane is the weakest, that's where the bone's going to flow. So I got a huge bump. Most of it went a little bit distal. I had enough to still place the implant. And this is what that Densa system looks like. So forward, normal, backwards, shoots bone up, and then they have some claims that you can do some ridge augmentations with it. I've primarily used it right now just for my internal sinus bumps as an addition to an already great kit. And you can kind of see all the dimensions. So if we're going up to a 3.8, I usually get up to 3, and I usually only use like these 2 burrs. Maybe this one when I widen the osteotomy, and then I go back to the Urus kit. You can see I didn't get how much bone we got up in there. This particular case, I asked for, because I don't have a lot of bone to work with, I didn't use their cover screw. A little technique that I was taught is get the smallest healing abutment possible that's a little bit wider than the implant diameter. So you can put that on, cover it up, and then you know that implant won't go flying into the sinus because you have a little bit wider of a healing abutment there. But you can still cover it because it's small and flat. So you can still get primary closure just to help to make sure you don't have to send it to any ENTs if something crazy or strange happens. That was tooth number 3. Tooth number 14, we had a lot more bone to work with, and you're going to see I used a custom abutment. Again, the offset is 9.5, and we did a custom healing abutment because I had a lot more bone to work with. Nice little dome as well. With that, nice little bone around placement, and now we're just letting that heal. So, it's been a fun ride. You're going to have some issues along the way. You're going to have some hiccups. It's not going to be some straight, smooth road. But to me, this is where this is my fun now, is kind of doing these implants. I'm not a big fan of when I see MODBLs, composites on my schedule. That's a lot more, I think, a lot harder for me than doing some of these surgeries now, is because it's very, very predictable with the kits and the systems that Urus and True Abutment have kind of worked out, and a lot more profitable. Something that, a quote that kind of resonates me is the only way to make sense of change is to plunge into it, move into it, and enjoy the dance. Jumping into that digital world 7 or 8 years ago, I've had an absolutely amazing run and enjoyed the dance. So if you're scared or a little bit apprehensive, try it, experience it, at least attempt it. And I think if you follow their systems and the recipes that they've created with their surgical guides and their surgical protocols, you'll be very, very successful in doing it. I'm going to kind of wrap it up. I was young, dumb. Those are two things that usually go hand in hand together. Is that when I was in college, I did a semester abroad in Australia, and the week before, or the 2 or 3 weeks before, my friends and I got to tour New Zealand. This is where the original bungee jumping happened, where they actually created it. And we all decided to go bungee jumping, and then the following day we were going to go skydiving. The skydiving, because of weather, actually got canceled. So I still have yet to go skydiving. But as we're getting up to this platform for me to jump off, they tie you up, and then they kind of walk you out to the platform, and your feet are kind of tied together, so you're like slowly jumping up towards the edge. And in the background, the music is Gangster's Paradise. Not the most uplifting song in the world to be jumping off. And they go 5, 4, 3, 2, and they get to 2, and the guy goes, stop. He's like, don't jump. And I'm like, okay. He's like, scoot back. I don't think I double knotted you. Yeah. So like I scoot back, and he leans me back down, and he looks, he goes, yeah, forgot to double knot you. I'm like, okay, and I'm supposed to go. So we get back, for some reason I decided to do it. I know it's an old video, this is probably 15 or 20 years ago, and you go bungee jumping. So it's kind of been a mantra or a thing that if you have the right technology and you believe in what you're doing and what you have, you need to kind of take a leap of faith at some point and trust all of your judgment. Maybe I wasn't the smartest one to be judging it at that point in time. But if you do it and do the right steps and have the right people and the right mentors around you, you'll have an amazing journey and an amazing ride. I still remember it, had a blast doing it, would probably do it again. I took my wife and kids there back to that bridge a couple years ago. My kids weren't old enough to do it at that point in time. My wife said once they're old enough, she'll let us take the whole family bungee jumping. We'll see if I actually get her commitment on that. But we're going to take a break. Let's do, if we can power through and do a quick lunch, and then we'll start doing some of the hands-on stuff so we can get you guys all to have an early weekend. Cool? Perfect.
We have lunch over there. You guys can hang out wherever you guys want after our lunch. Dr. Hagan is here to help you.
So if you want to learn, we talked early in the lecture on how to restore implants with the True Abutment system and the CEREC system, and he's the one that teaches it. Yeah, next month. So ask Jay, ask Storm, or Dr. Hagan when that is, and you guys can come back in this room. Half of it's done in here, half of it's done on the computers where they have like 15 or so CEREC machines to work with. Do you guys actually have mills too? No mills? But 3 mills. So you can mill your own crown, learn how to cement it on the tie bases, all that kind of stuff.
And before lunch, I don't want to bother you guys after the seminar is over. So if you could have everybody just stand outside for a group photo, and then we'll grab lunch.
Sure.
Yep.
Outside real quick. Don't get locked out like I did.